Finally, I look forward to engaging discussions and collaborative efforts to improve the well-being of families affected by this condition. Thank you for your dedication and participation. For the sake of the time, please allow me first, before I introduce the first speaker, to welcome our distinguished guests, Dr. Abdullah Al-Hamaq, the Executive Director of Qatar Diabetes Association, Dr. Samira Al-Hajri, the Director of Occupational Health and Safety Primary Health Care, and our Dr. Hassan Qasim, the Chief Medical Operation of at Qatar Red Crescent, and all the attendees who honor us to be with us today. The first session will be empowering individuals at risk of diabetes. Will be presented by Dr. Tayyib Abdelaziz. Dr. Tayyib is senior consultant physician and endocrinologist at the View Hospital and assistant professor of medicine at Qatar University. Welcome, Dr. Tayyib.
Yeah, colleague, thank you very much. It's give me a great pleasure to be with you today. And without any further ado, I'm just going to start this session. Right. So I thought it is the sound. I thought I'm going to talk about first. Why do we need to talk about this? Okay, the magnitude of this point globally. Can we really prevent type 2 diabetes? And what are the available diabetes prevention programs? What are the evidence behind them? Then I share with you a clinical scenario before sharing with you my tips about empowering people at risk of diabetes and the practical challenges that we have, and then a summary then able to take any questions or comments. I'd like first to start with the personal story. So, back in 2016, I was on my fourth year training as a registrar, and it happens that we are doing like an audit about the freestyle library, which has been recently reported at that time in the UK with the very safe criteria. And I was participating in that, so I thought, well, I will take one and I will see. And I was thinking that I'm young, I'm doing all the right thing, but I stick it, and I was really surprised with the spikes that I have when I eat a cortisol in the morning on healthy start, when I do exercise, and then I checked my HbA1c, I find myself, my HbA1c is 5.9%, which was really a high opener. So I thought, okay, I started to make some changes based on that, and I started to make changes in the diet, doing some exercise, and I also shared this experience with my dad, asking to check his blood sugar, and his HbA1c came to be 9%. He's never known to have any medical condition. So through some lifestyle changes and through some tips that I'm going to share with you, its last HbA1c now, as of yesterday, is 6.2%, just through lifestyle medication and 1,000. So that just gave me insight about the hidden magnitude of the problem if we are thinking that we need to wait until we have some symptoms or sign, or if we are putting ourselves as in a specific category of disease. Right. So we all know that at the moment there are almost 600 million adults has diabetes, and 40% of people with diabetes are not diagnosed, and there are about 600 million as well that live with diabetes, with a huge cost on our economy. In Qatar, I think there is about between 8 and 10 billion Qatari riyal for annually for diabetes and its complications, which is huge. And again, in the UK, for example, that's almost 12% of the funds for the healthcare system, which is about 20 billion pounds. So we are facing a problem that is very huge and very costly, and we are not able to afford it cost just through the treatment. So we need to do something. How is the situation in Qatar or in the Middle East? So according to the prediction that we are expecting in the MENA area to increase by 92%, going to 162 million patients going to be living with diabetes. And this is a huge number for a country their population range between 3 billion and Saudi Arabia is about 30 billion. If you look at the North America with a list of 300 plus million, the numbers is about 56 million. Look at our MENA area is only 62 million. That will give you an idea about the magnitude of the problem. And this study has been done through the work on Mill back in 2023, concluded that there's about 20% of people, the prevalence of the disease has increased by 20%, and it's expected to increase to about 30% if we didn't make any intervention. And are we doing good in treatment? This is might be a little bit old from 2012. However, there is no country, zero, nil, achieving the target of treating diabetes. And we know about all the complications associated with diabetes. And we know that the moment that you are diagnosed with diabetes is equivalent for having heart attack. And actually, diagnosing you with the diabetes, you are losing 6 years of your life if you have diabetes and ischemic heart disease. That's 12 years. If you add on that a stroke, that's 15 years. So your counter, if you are 60 years old, your counterparts might live up to 75 and you might die at 60. So that's a huge burden of diabetes. So I hope I was able to convince you that diabetes is really a global pandemic that we cannot afford to treat. There is no healthcare system able to treat that. And there's a lot of issues that from the doctor, from the healthcare system, and from the doctors, I think we are addressing diabetes similar to many acute problems. We are really good as doctor in making acute problems. If you have pneumonia, you are treating the underlying cause, and that's it. If you have UTI, you are able to treat that, and that's finished. But that strategy doesn't work well for chronic disease, which we are not handling really well. Because I think we are just masking the symptoms. High blood sugar is the symptom of diabetes. It's not, shouldn't be the target of treating the diabetes. Because if you have a patient with pneumonia, you just don't treat fever without treating the underlying infection with the appropriate antibiotics based on the culture. But that's what we are doing. We are just treating the numbers and ignoring the underlying factors that leading to diabetes. So we need really to shift our focus from treating the symptomatology, treat the etiology if we are going to tackle this. And now we are seeing young people with type 2 diabetes. I don't remember since I graduated that I have seen a patient who is 12 years old with type 2 diabetes, because it says, well, type 2 diabetes is a disease of adult people for 5 years old, but now all of you have seen those patients who are 15 and 16 years old and having type 2 diabetes. And looking at the life expectancy and knowing that the legacy on diabetes memory associated with diabetes, the earlier that you are diagnosed, the more risk you will have, the more complication that you will have, and shorter life that you live. I'm going to skip this one, but we know it's our lifestyle that we really need to change. The universe is getting fatter, we are getting bigger. We are moving less, we are eating more. Even the animals, if you look at the cats and the dogs, they're really getting also fatter. And this is a problem that we have transferred even to the pets. Now, moving to before the emergence of the disease, this is a study has been published back in 2007 by Kent Peterson and Gerald Shulman, looking at 300 individuals who have parents with type 2 diabetes. They are fit university students, they have idle life, they are non-smoker, and they just did an OGTT. And as you can see, although their blood sugar is normal, however, that is at the expense of high insulin. The insulin is actually doubled. So the marker is not working, but I think you can see the yellow line to achieve the same level of blood glucose. Those people are really working very hard and working extra time. And this is not without risk. Because we know is hyperinsulinemia is a benign problem. We know what is insulin. It's not just about chemical hormones.
Also growth hormone, right? So for people with acromegaly, we are measuring the IDF1. And if you have uncontrolled growth, what is that? As cancer. And it's not surprised that hyperinsulinemia is associated and diabetes is associated with more than 13 types of cancer, including the colorectal cancer and breast cancer as well. So hyperinsulinemia is not a benign condition, and it's associated with a lot of complications, but it doesn't see that we are checking it Are we treating those patients with hyperglycemia, or are we waiting for them to reach the pre-diabetes stage, anti-diabetes, and then start on the treatment? I think there's a lot of data and studies that showing physicians are initially starting the treatment, so rather than treat to carby, they are treating to failure, which is an old model that we used to have. So I think we need the big idea in people who have normal glycemia, hereditary hypoglycemia. If we wait for them to go to be the diabetes and even more than be the diabetes, I think we failed. It's really a health system that we are dealing with. I think we are not a health system. I think we are a disease system, right? Because we are looking at the people who are ill and sick. And we are not looking after the people who would like to be healthy, because you can see the magnitude of the problem. Nobody can afford to treat those patients. And if you are working with the private sector like myself, you are really going to struggle to convince the insurance company to give this patient any treatment. They will wait for him to have a HbA1c of a certain target to allow you to give some treatment for it. Right, so I'd like to share with you this scenario, very common scenario. It's available, I'm sure you have seen this patient in all of your clinic, young chap with a family history of type 2 diabetes, mom at risk as well, and he has sister who had also pre-diabetes, and he is scared of diabetes, right? So this is our patient. If we look, he had a father who has type 2 diabetes, his mother had gestational diabetes, his sister recently diagnosed with pre-diabetes, and he's a little bit overweight, sedentary lifestyle, and a student as well. Not a smoker, but he admits that his lifestyle could be improved. So those are the whole risk of diabetes that we are aware of, and most of them are in this patient. So what are our strategy to empower this gentleman? So first, we need really to acknowledge his fear, because really he is at risk. We shouldn't just fluff it away and say, well, your blood sugar is okay now at the moment, we see you in a couple of years. I think we should start now acknowledging the problem and explaining for him the modifiable risk factor and highlighting that, yes, he is at risk, but that doesn't mean that this is his destiny. Because I have a lot of people that tell me, well, my dad had it, my mother had it, I'm sure I'm going to have it. So it's not the case. Even if you have diabetes, you are able to put it into remission. And I think that's the message that we need to pass to our patients, and we need to help them to make a shared decision for themselves, rather than just dictate some instruction for them to follow. So those are just some suggestions about how he will be able to tackle this problem, because probably he will be overwhelmed. So we need really to start small with bits that he is able to incorporate into his life, in his daily life routine, rather than just giving a manuscript of copying it from the WHO or IDF or NICE guidelines that is not fitting the patient, because we know that culture affects the patients and their behavior, also their family status. There's a lot of reasons that we need to address to make an individualized management plan. I will share with you only one study about the diabetes prevention program, which reviewed more than 3,000 participants at 27 centers in the UK. Some of them, they just monitored them. The other, they gave them metformin 850 milligrams twice daily. And some patients, they did active intervention through lifestyle interventions, one-to-one education for 1 year, and then healthy eating and active exercise about 150 minutes per week. And they lost not much, only 7% of their weight. And look at the results. People who have drug therapy with metformin, they reduced the risk of type 2 diabetes by 31%. Good. Lifestyle, 58%, almost double. And I know you might say, well, they will not be able to continue on this. And I can share with you that after 10 years, the risk is still lower, it's 34%. And if you are over 60, it's 71%. So it has no age. If you are old, if you are young, start now. And the evidence is backing that up. This is just the epidemiological study, and we can see, as I said, in 10 years' time, the benefit of lifestyle intervention is there. So those who did develop type 2 diabetes, they delayed their onset by almost 4 years. And if you put in your mind that the legacy effect that we are all aware about, or the diabetes memory,
even if you develop diabetes later, your complications are less. So it's still a benefit. We will try to avoid progression to that level, but that is still a huge step. Right. This is another study from China. Basically, it did the same, 25 years, and I think they published their data of 30 years of follow-up in 2019. Still, lifestyle intervention is paying off. And I'm not going to talk about also the effects on the cardiovascular because other colleagues are going to mention that. I'm going to skip this one. So, it's our lifestyle that we need to change. Previously, the hyperinsulinemia, it was for a purpose because there was a scarcity of food, right? So when you eat after a couple of hours, couple of days, then there will be a surge of insulin for you to use that energy and then to store that amount of energy and calorie as a glycogen when you need it in the case of starvation. And that balance was fine. But at the moment, with the abundance of food, it's always eating. You are snacking, you are eating, you are moving less. So what's happening? That amount of insulin is just going to store glycogen, then it's changing it to a fat, then your body weight is increasing. And what seems to be a blessing, it turned out to be now as a curse. It has been said before that let food be thy medicine and medicine be the food. And also in our religion, we know there's a lot of verse about المعدة بيت الداء وأصل الدواء وحسب ابن آدم لقيمات يقيمن صلبه. We have the fasting as well and the benefit of fasting. So that's all for a reason if you look at it. Right. So that's good and well. But what are the challenges? Healthy lifestyle is expensive. If you subscribe to a healthy meal, that will cost you more than the junk food that you can easily get. And again, people are busy. They only get aware when they get something. They get pain, they get some complication. But who is going to look after, oh, I have a little bit high insulin. He's looking after his study, his family, his work, a lot of projects that he's running on. So that awareness, we need to put it for patients. Again, are our countries supporting it? I think there should be some stakeholder. For example, some countries are now aware about this. They are putting some taxes on the sugar for the parking space. If you are going to park near your work, you need to pay more, so you will be able to walk as well. There's a lot of like strategies to help people make good choices for their life. Right. So, does those small changes work? Yes. So, as I showed you in the DPPP, that this can cut your type 2 diabetes to half. Right. As I said, health policies and healthcare practitioners, we need to change our view of tackling the problem. This is a very busy slide, but you might want to take a photo of this. I think we are focusing on secondary prevention. All the money we are putting is in the secondary prevention, but we need to shift our focus to the primordial and primary prevention rather than the secondary prevention. Last thing, we need to use technology. And I know, like, people who are, you know, the Gen Z are looked after by the boomers or the Generation X. There is some gap on our patients that we are treating who are now tech savvy with their consultant who might be a little bit behind on that. So this, again, something that we can utilize. This is just an example of a program, just depending on the AI. This is just one face sheet showing you what is the suggestion that program giving to the patients, giving him suggestions of healthier options, and you can see the data. There is a significant decrease in the glycemic variability in all the groups, from health individual, people who have insulin resistance, prediabetes, and even type 2 diabetes. Right. So, in a nutshell, this will be my... So, small changes and encouraging health lifestyle modifications do work, and we need to focus our shift from secondary prevention to primary prevention. Public health policies and use of technology are crucial in addressing those risks. So, in one family, you will have a lot of people, everyone having a different path and leading different journey.
And to address that problem, you need to address the problem in the environment. Because, for example, you will tell the patient, well, reduce the carbohydrate, anything white like rice, pastries, those things, don't eat them. But who is cooking for him? What is his culture? We have a lot of South Asians. This is their food. This is the cheap thing that they can afford. So just giving those like instructions not going to work. And you need to address the whole family rather than the one person. So personalized support matter and knowledge is power. And I'll stop here. I'll be happy to take any questions. Thank you.
Thank you very much, Dr. At-Taib, for setting the scene. Just stay here. And before actually we move to the question and answers, I would like to actually welcome the top distinguished actually faculty, Professor Peter Schwartz, the Global IDF President. Welcome, Peter. It is great to have you here.
Very nice to hear you.
So thank you very much.
Very nice to hear you.
Yes. The center stage is yours.
It's a great honor for me to attend this meeting, and I was listening the talk just now. And first, I would like to apologize for not being in person there. But due to the attack 2 days ago, the fees for the insurance of the International Diabetes Federation to travel increased dramatically. So it was nearly impossible then to come directly after the attack to Qatar. But I want to use this opportunity, digitalization in health education, to participate in person. I'm sitting in Dubai and wait and listen to the talk. So it's especially an honor for me because the topic of this STEPS program means what we have to address in the future in diabetes care. Diabetes is a disease which is not starting suddenly. And we heard it in the last presentation very well. It's eating behavior. It's a development of insulin resistance. It's the development of fatty acid metabolism over years, over decades. And it's a dysglycemic continuum. And as earlier you start, as better is a chance for prevention. So the idea behind this program is we have to take early steps to prevent diabetes from developing. We have to take early steps to address the need of people living with diabetes. And we have to take early and I would say aggressive steps to prevent cardiovascular comorbidities, kidney, renal comorbidities, and micro and macrovascular comorbidities of people living with diabetes. And this is a topic we would like to discuss here today. And let me take the chance to address what we just have heard from the first speaker. And there was one very slight sentence, and he pointed out on the slide and said, at this point, we have to start. And for me, this is a key message of this lecture, saying we have to start in a situation where there is still normal glycemia, but insulin resistance. And if we are able to address this point, let's say at point of care or point of intervention, then we have the chance to lead to a remission or prevention of diabetes. And then there was a second word, what was very, very strong in the lecture, and this was fasting. And it was very short, but I think there's a big opportunity for this, for prevention and remission of diabetes again, but we will come later to this. So thank you very much to the chairman, Dr. El-Had and Dr. Morsi, for arranging this program. Thank you very much to every one of you to be here to discuss it. And let's take the necessary steps for successful prevention and better care of diabetes for people living with diabetes. Shukran. Thank you very much.
Thank you very much, Peter. It is great to have the top person actually in IDF leading such initiatives. Back to Dr. At-Taib. If I may, just would like to ask you a few questions regarding the DBBS program, which has been done exclusively in a sort of a more or less purely Caucasian population, and then the Dakwing study from China. Just a comment to say that actually in Qatar, we are very much blessed to have our own Qatar diabetes program. And I'm very pleased to tell that actually Dr. Mohammed Bashir and the other investigators actually from Hamad Medical Corporation, they are just about to start another sort of similar prevention program. And this will be actually an addition to what we already know about the quest to try to prevent diabetes.
Yeah.
So just I would open the floor actually for any questions for Dr. Taib. So if I may just to ask you, you alluded to the fact that, metformin does actually in DBBS drop your risk of diabetes by 1/3.
Yeah.
And lifestyle drop your risk by 2/3.
Yes.
So if you combine them both, of course, this will actually give a better niche for prevention of diabetes.
Yeah.
What do you think about that?
Yeah. So I think from real life practice at the moment, and combining this obviously is going to give you more additive. And actually, metformin is an old drug since 1920, but it's still showing us great benefits. Particularly not only in people who have diabetes, because when I look at it as a spectrum. So we are measuring the blood sugar, but when you look at your patient data, you can see your HOMA-IR is high, his ALT is high, his triglyceride is high. Those people will really benefit from the metformin, and I think the recommendation is that I think for prevention on those patients, we usually reach a maximum of 1.5 gram per day, not the 2 or 2.5 gram that we give for people with diabetes. And there is great evidence that will help, because we know that the lifestyle sustainability sometimes is an issue. So combining this will give you really huge benefits for your patient to delay the progression of type 2 diabetes.
Professor Peter Schwartz, any comment?
Yes, I would like to comment one of the aspects which were mentioned in the talk, and this was regarding taxes on food items. And this, there is a lot of science around this. These are very, very promising strategies. And you may laugh now, Pakistan is a country who's one of the frontiers in the world in implementing this. They have a tax on sugary soft drinks, including those with artificial sweetener, which is a very important point to include those with artificial sweeteners. And they developed a public health policy, a ban mile around every school to forbid to sell fried products. And if we now jump to Africa and go to Mauritius, Mauritius has now fixed fasting in the national health policy as a first type 2 diabetes, and Tahiti already has fasting as part of obesity and diabetes management in the constitution. So there is a development. You know about the strategies also in Mexico, in El Salvador, and in many other countries in the world, and also here in the region. There is a lot of discussion about modern public health policies. Take this chance, because this changes the environment for people living with diabetes or people having a diabetes risk, and it makes a big difference for them.
Thank you very much, Professor Schwartz. Any questions, please, from the platform, from the audience?
I may ask Dr. Taib one question. Dr. Taib, what about regarding metformin? What is the best cut line to start it? Because you know the pre-diabetes starting from 5.7. Some guidelines mention from 5.8, some from 6.
Yeah.
Which cut line you wanted to start?
Okay, so the guidelines actually didn't recommend really, there's no clear advice on that, but we need to take that with a pinch of salt, because I have shown you the amount of money that it needs. If you put that cut, then for policymakers, you are bound to treat those patients, and the health system is not able to afford that. But I just transfer this question to another things. Do I recommend using freestyle libre for people who are pre-diabetes or at risk? Yes, I do. Is the health care system able to offer that? No. Are they going to benefit? Yes. So if you have all the resources and you are able to afford it, if I take the money out of the equations, I think you are going to choose that to prevent. So the short answer is, practically, if the patients and the system can afford it, yes, we'll do that.
But unfortunately, we need to focus on the people who will benefit more because we know that our resources are finite and we need to utilize them cautiously.
Thank you very much, Taib. I think for sake of time, I would like just to
Thanks.
welcome my other co-chair to introduce the next speaker. Yasser.
Thank you. Thank you, Dr. Tariq. Now we'll have the second session. I know we are a little bit behind the time. The second session will be pre-diabetes, a critical window for prevention. Will be presented by Dr. Muhammad Rishi. Dr. Muhammad is consultant endocrinologist and the head of endocrinology department at Al Ahli Hospital and the assistant professor of medicine at Qatar University. Welcome, Dr. Muhammad.
Thank you very much for the organizer to invite me today to give a talk about critical window for prevention of diabetes. And thanks for the attendance, and thanks for Professor Schwartz, who's following us from Dubai. This is my disclosure. So why we do care about pre-diabetes? Is it not only because it keeps us in the job and we carry on seeing more and more patients with diabetes, but there's more important factors, actually. It is high prevalence, and it is reversible, and prevention works. Early intervention can delay or prevent type 2 diabetes and reduce cardiovascular risk. Of course, the second important point why we do care about pre-diabetes, patients that can progress to develop type 2 diabetes. Individuals with pre-diabetes are significantly more likely to develop type 2 diabetes. The third important point, high cardiovascular risk. So pre-diabetes is linked to an elevated risk of cardiovascular disease even in pre-diabetes is developed. We start with the prevalence. How prevalent is the pre-diabetes? There is a common say for every one diabetic patient, there's 3 pre-diabetic patients. And if we look to the data from the United States, the prevalence of diabetes is 9.4%, but the prevalence of pre-diabetes is about 34%. And it's not all, is actually pre-diabetes involving both impaired fasting glucose and impaired glucose tolerance test, which is the majority of patients, they do have impaired fasting glucose. It's about 20% out of 34% of the population in the United States with pre-diabetes. About 20% of them, they have impaired fasting glucose. And for about 5%, they have impaired glucose tolerance test. And about 10%, they have combination of both impaired fasting glucose and impaired glucose tolerance test. And these type of patients who really stand higher chances for developing type 2 diabetes. So what about the progression of type 2 diabetes? So the definition, if you look, you can use the hemoglobin A1C 5.7% and to 6.4% as the defined patient of pre-diabetes. But the progression of pre-diabetes is about 10% of patients with pre-diabetes. Every year, they will progress to develop type 2 diabetes. So if you have 1 million patients with pre-diabetes, 100,000 patients of them, every year, they will develop type 2 diabetes. So what's about the risk of developing type 2 diabetes over 15 years period? So if we look for this study published last year in Diabetes Care 2024, it showed 15 years risk of developing type 2 diabetes, 25% if your hemoglobin A1C about 5.5%. And there's about 50% risk if your hemoglobin A1C at the baseline about 6%. So the risk is increased over years. So from over 15 years period, 25% to 50%. What about the risk of cardiovascular disease among patients with pre-diabetes? Actually, there was a study showed that if you are normal, you have normal glycemic parameters, your risk of developing cardiovascular disease is about 6%. And if you are pre-diabetic, the risk about 12%, so double from 6% to 12%. So it is two-fold increase in cardiovascular disease, adjusting for all cardiovascular risk factor. Patients with type 2 diabetes, we know they have about 3-fold increase for developing cardiovascular risk. And there was a recent meta-analysis, it was about 2 years back, found that pre-diabetes at the baseline was associated with increased mortality and increased cardiovascular event rates. Exists absolute risk, so about 7.3 per 10,000 patients showed high mortality, and 8.7 over 10,000 patients showed cardiovascular disease during the 6.6 years period. And now we see patients with pre-diabetic, actually they do come with peripheral neuropathy and other related diabetes complications. So of course, this leads to an intervention. And my colleague, Dr. Al-Daib, he mentioned about lifestyle intervention. And these are the studies which actually involved either lifestyle by its own or lifestyle plus medication. The first one, the China Diabetes Prevention Program, I highlighted the one in red color, these the studies which we're going to touch on more. So the first one, China Prevention Program, is either metformin and lifestyle intervention. The second one, the Finnish study, only lifestyle intervention. The Indian Prevention Program, both metformin and lifestyle intervention. And the USA, the Diabetes Prevention Program, the USA program is both metformin and lifestyle. If you look to the oral hypoglycemic and injectable therapy, excluding the GLP-1 receptor agonist, you can start from the metformin study, about 31% reduction, and acrobos, 18% reduction, the insulin glycine, 20% reduction, and then you move to the heart failure, which shows 32% of preventing progressive diabetes for patients who are pre-diabetic. So these are the studies which highlighted in red color. We start with the Finnish studies, about 3.2 years. Diet and exercise only, it showed 58%. And the second one you say is, again, it's about 2.8 years, and it showed exactly the same figure, actually, 58% preventing or delaying diabetes by only lifestyle modification. So exactly the same result between the American Diabetes Prevention Program and the Finnish Prevention Program. If you move down a little bit to on the slide, and you can see the Indian Prevention Program is about 30 months, involving either lifestyle modification and metformin twice daily, or the combination. And the question of Dr. Al-Had about what about combining metformin and lifestyle? Actually, the Diabetes Prevention Program in the United States does not address this matter, address either lifestyle by its own or metformin by its own. But the Indian Prevention Program, they do actually answer this question by combining metformin and lifestyle modification. And you can see it's 28% of patients that have metformin and lifestyle modification. It's slightly better than metformin by its own. Again, the Chinese study as well, they addressed this question where combining the lifestyle modification and metformin together, and you can see the Chinese, they did much better by 62% reduction. We go into more details in the Finnish program. It's about 500 patients. The control only diet and instruction at the onset of the study, and individual patient advice given 7 times in the first year and every 3 months thereafter with the goal. These are the intensive arm. So just the control group, they just given them standard advice. The intensive arm, they given them 7 times advice per year, and then see the first year, and then seen every 3 months. And the weight loss target, it was more than 5%. The second target, reducing fat intake by 30% of energy consumption. And the recommendation for fiber, about 15 grams per 1,000 kilocalorie. Because somebody eating 2,000 kilocalorie, he need to have about 30 grams of fiber. And they advise them to have exercise every 30 minutes. And the primary endpoint, prevention of type 2 diabetes, assisted by oral glucose tolerance test. So what's the outcome of the Finnish prevention diabetes program? And it showed actually reduction or preventing type 2 diabetes by 58%. And it's not only this, it showed there is an improvement in the fasting blood glucose and the 2-hour post-branded blood glucose and reduction in fasting insulin and 2-hour insulin. So lifestyle modification nutrition is the cornerstone for diabetes prevention. Moving to the bigger study, which is the American Diabetes Prevention Program. Actually, this study started in 1996, and the recruitment continued for 3 years until 1999, and they published the data in 2001 after 2.8 years. However, the program continued for 10 years data and 15 years data, and we'll touch on in a minute. So this is the randomization, about 1,000 patient intensive lifestyle, second group about 1,000 metformin, and the third group neither metformin nor lifestyle modification, unless the patient, they did their own initiatives. And what's the results? So the first, at the end of the diabetes prevention program, 2.8 years, is 58% of patients delayed to prevent diabetes by lifestyle only. By metformin, about 31%. What happened after 10 years? After 10 years, you can see the effect of the lifestyle becomes less from 58% down to 34% and 18% for the metformin. And we need to highlight that 71% of these patients, their age more than 60. And what's the interesting, there was 16% reduction in diabetes risk for every kilogram of weight loss. So if you have your patient coming to see you with 2 kilograms of weight loss, you need to actually be happy with the outcome, because only 1 kilogram of weight loss reducing the risk of developing type 2 diabetes by 16%. So what happened after 15 years? You can see the prevention intensive lifestyle program is reduced by 27%. We know people who are older, they become less, they move less and they put in weight. So the efficacy of lifestyle intervention and the sustaining the lifestyle intervention as well is not easy. But the interesting thing, if you look to the metformin, actually, after 10 years, the metformin is prevented with the rate of diabetes by 18%, and after 15 years by 18%. So there is sustainability for over years with using metformin. Looking to the risk for the intensive lifestyle group, 4.8% of them, they do develop diabetes. Okay. And the metformin group, 7.8% of them, they develop diabetes. And the patient who they don't do this or that, 11% of them, they develop diabetes. What about the weight change? You can see after about 4 years period, the metformin group, they lost about, in average, about 2 kilograms in weight. And the lifestyle group, they lost about 4 kilograms in weight. And coming back to Dr. Tariq's point, what about combining together? I always mention to my patient, if you have 31% and you have 58% common sense combining both together, you have 90% a chance to prevent or delay diabetes. Similar to weight, if you have 2 kilograms over 4 years with the metformin, and 4 kilograms with lifestyle, if you combine both together, you'll have a chance for having 6 kilograms of weight loss. But what's interesting, this graph, if you look to the lifestyle, you can see significant weight loss in the first 2 years, but patients, they find difficulty to maintain, and they start to put weight again. And the evidence showed 90% of patients who are on lifestyle, they do end up with weight gain again. What about the hemoglobin A1C? You can see, again, with the lifestyle, a significant reduction in the hemoglobin A1C over a period of time, with the first 2 to 3 years with lifestyle. But again, the metformin and the lifestyle, again, they met in the same hemoglobin A1C after a period of 4 years. What are the 10 years incidence? You can see still the lifestyle doing better than metformin. Now moving to the Indian diabetes prevention program, and interesting actually, the lifestyle is not doing as good as the American diabetes prevention program. It's only 29%. But if you look for the metformin, it's 26% of patients delayed or prevented diabetes by taking metformin only. And the lifestyle modification plus metformin is just doing slightly better than metformin by its own, and nearly equivalent to lifestyle. And probably the South Asian probably have the central obesity, maybe the metformin doing better with people they are centrally obese comparing to people who are diffusely obese. What about the Chinese? And very interesting data for the Chinese. Actually, the patient who took the metformin compared to control group, they delayed or prevented diabetes by 65%. And this is, you can see the outcome for the Chinese diabetes prevention program. Metformin plus lifestyle intervention group had 17% lower incidence of diabetes than lifestyle intervention alone group. And you can see the metformin is in the red color and the control group in blue color. If you look to the incidence after 2 years lifestyle intervention patient, they have incidence 25% comparing to patient who they took metformin plus lifestyle. So metformin plus lifestyle in the Chinese prevention program, they did better, it's about 21% reduction. So Dr. Yasseri asked about the guidelines, and this is the answer for you, in particular for metformin. So the American Diabetes Association guideline in 2025, in addition to lifestyle modification, regular physical activity, medical nutrition therapy, physical activity, and behavior therapy, in certain individuals, particularly those at higher risk developing type 2 diabetes, metformin may be appropriate for adults aged 25 to 59 with BMI more than 35. I think the BMI, in my opinion, is too generous to include it with above 35. But again, probably this is a cost issue, although the metformin is not an expensive medicine. Or elevated fasting blood glucose, and they used hemoglobin A1C 6%. And actually, the hemoglobin A1C, again, this is used in the NICE guideline as well for using metformin for diabetes prevention. And the other recommendation, as well, those with a history of gestational diabetes. And probably Dr. Bashir is going to touch on more, but he can use, because there are higher risk of developing diabetes, patient with previous gestational diabetes, so metformin have a role. So, however, what the guideline said, metformin is not a blanket recommendation, so it's not for everybody. Although, in my opinion, if you have a normal kidney function, have BMI, I think the metformin is a good medicine, but I am biased. I did my research back in year 2000 in Sheffield University about metformin and polycystic ovary syndrome. And at the time, it was 350 publication. I just looked last night, there's 3,500 publications about metformin overall use, but so far we don't understand everything about it, but it's a great medicine as far as the diabetes prevention is concerned, and polycystic ovary syndrome as well. So metformin is not a blanket recommendation for all individuals with prediabetes, but rather a consideration for those at higher risk of progressing to type 2 diabetes. So in summary, metformin in prediabetes is proven and guideline endorsed. Metformin is, Dr. Al-Had, still there's a few slides to come on, so we can. Metformin is well-established, guideline recommended therapy for delaying or preventing type 2 diabetes in high-risk individuals. The optimal dose, 850 milligram twice daily, and this is what showed in the evidence. So if you give 500 twice daily, you probably don't get the results which you wish to get. Metformin immediate release showed in the diabetes prevention program is 78% tolerability reported. And while the metformin XR may offer better GI tolerability, immediate release remains effective and accessible. And there's cost issue as well. So metformin is a low cost, generally well tolerated, and supports modest weight loss, adding to metabolic benefit. However, we should always mention diet and exercise remains the foundation of diabetes prevention with or without metformin. Of course, talking about diabetes prevention, we cannot move without talking about other tools which we have now, which is GLP-1 receptor agonist. And this is the tirzepatide with Mounjaro for obesity treatment and diabetes prevention, which is a SURMOUNT-1 trial. Over 3 years, mainly they looked for weight and glycemic outcomes. And this is the slide from the efficacy results as far as the diabetes prevention is concerned. And you can see from this slide, actually, there is 93% risk reduction for progression for diabetes. This is over 176 weeks. And the patient who was treated with the Mounjaro, it showed only 1.3% developed type 2 diabetes. Comparing to placebo, is 13.3% for the developed type 2 diabetes. That's why is 93% of patients showed reduction in progression in type 2 diabetes over 176 weeks period. But however, what about after 176 weeks? Now moving to the semaglutide, we'll go with high-dose semaglutide, 2.4 milligram. And this is a step 10 trial designed to randomize a double-blind, multi-center controlled trial. And again, they use the NICE criteria for pre-diabetes, which is the 6% to 6.4%. So it was inclusion criteria, and BMI above 30, age above 18. And it was over 52 weeks. And they look for change in body weight and proportion of participant reverting to normal glycemia. So mainly for pre-diabetes and weight over 52 weeks period, and they used the titrating up dose of oral semaglutide or Wegovy up to 2.4 milligram. And what it showed after 52 weeks, and you can see a significant reduction in preventing or having number of patients who they end up with normal glycemia is about 81% comparing to 14%. So this is in a 52 weeks period. What happened after 81 weeks period? And this is what's always the case about the GLP-1 receptor agonist. For how long are you going to use it? And from our experience, patients, they come after a period of time, they said, doctor, we are not losing any more weight. And evidence showed that actually. After only 30 weeks, about from 52 weeks to 80 weeks, all dropped from 81% of patients prevented or delayed the progression of to diabetes down to 44%. So 50% of them, they have drop in or delaying and preventing of diabetes. So just a case, this patient, one of my patients, she's 58 years old, pre-diabetic, her A1C is 5.9%, using steroid, and her mobility is limited. Her BMI 72.8%. So what's the next step of managing diabetes for this patient? Who going to give this lady metformin? Hands up, please. Only 3 people? Okay. Who's going to give Mounjaro? Only 1 person? Okay. Who's going to give Wegovy? Or are you shy? Are you shy? Okay. Any other suggestion? Lifestyle, she have mobility problems. So diet, you can do diet. Actually, basically, I looked to this. I want to answer this question. So I looked to the cost effectiveness of using metformin and either Wegovy or Mounjaro. And if you're going to prevent diabetes, if you're using metformin and reducing the risk by 31%, you need to treat 14 patients, but it's going to cost you over 3 years only 12,000 riyal. If you're going to use Wegovy, or you need to treat 10 patients, over 3 years it's going to cost you nearly 500,000 Qatar riyal. Just 1 more minute. If you're going to use Mounjaro, it's going to cost you 400,000 Qatar riyal. Either you have Laxis or you have Mounjaro over a period of 3 years. So, and we have an evidence for metformin over 15 years period. We don't have that evidence for the GLP-1 receptor agonist. So I would like to summarize here. Turning the window into action. Pre-diabetes is not a mild form of diabetes. It is a critical early stage of dysglycemia that can be reversed with timely intervention. Without action, up to 70% of individuals with pre-diabetes may progress to type 2 diabetes. Early intervention is proven, it works, and cost-effective. Preventing diabetes is far less expensive than managing its complication. Investing in prevention saves both health system resources and improve quality of life for individuals. What's the way forward? Call to action. We must screen early, particularly patients with high risk. We must educate, empower patients with education and resources, and intervene with established system-wide protocols for diabetes management. I would like to thank you, and I would like to advise you, eat well, move more, and live longer. Thank you.
Thank you very much, Dr. Arishi, for such a wonderful presentation. Would like just to get our distinguished IDF president for an interaction. If you could just step on the side. Peter, any comments for Dr. Arishi? I think you are a bit mute, Prof. You are a bit mute.
The question to Monjaro. If we are honest, every one of us was already thinking about taking Monjaro or not taking Monjaro. And if you are in the UK, 85% of the Monjaro is paid by out of the pocket in an environment where it's fully reimbursed. So there are many, many people buying Monjaro. And there are also good reasons, or let's say there might be good reasons to do it. It helps with sleep apnea, you lose weight, and you lead to a remission of diabetes. So it sounds everything good, and the molecule is brilliant, I would say, but it's not the solution for diabetes. If you stop any of the GLP-1s and the dual agonists, and also the triple agonists, which will come in the future, if you stop them, after 3 to 6 months, the weight comes back. And if you lose weight, you lose fat mass, which is good, but you also lose some muscle mass, which you need to carry the fat. And if you gain weight, it's very fast that the fat mass or the muscle-free mass is coming back. So on a long-term perspective, we have still to investigate and do research on the GLP-1 story to make it more efficient. Yeah? I think the first person who finds a solution that you use GLP-1 or dual or triple agonist for 2-3 years, and then you cease this together with any other intervention, and you reach a sustainable effect, this will be the winning model. The combination with metformin is very interesting. The combination with fasting is becoming even more interesting. But I think the most sustainable one is changing the lifestyle. And we will come to this later on as well, how the fasting can be also an opportunity. Then you also highlighted the metformin. And for me, metformin is one of the most powerful drugs in the diabetes sector. It's 102 years old, developed to treat Spanish flu, then it became a diabetes drug. And today there's a good reason for all of us to eat metformin because it's preventing cancer. So it's the power of metformin is actually, we could say, even already more in the cancer field than in the diabetes field. But it's a drug which is available worldwide. And so combining it with semaglutide now in the moment, in the very low and low income environment worldwide, so Southeast Asia and Africa, the GLP-1s make diabetes care 22 times more expensive, but metformin is available everywhere in the world. That's why, for me, the start of any action in diabetes sector is metformin, 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 and then we could think about anything else beside lifestyle intervention. Lifestyle always comes first. So thank you very much for this very cool presentation, highlighting also the opportunities, but also challenges of pharmacological treatment for prevention of diabetes.
Thank you very much, Peter. And unfortunately, for sake of time, we don't have any added privilege to, so please leave your questions to Dr. Arishi for the end of the session. We will have another dedicated session for question and answers. Gives me my pleasure to welcome again my co-chair to introduce the next speaker, Yasser.
Thank you, Dr. Tariq. Thank you, Professor Schwartz, for this intervention. I have very little announcement for modification in the agenda because we are behind the time. There will not be a break, okay? After the third session, we will continue the fourth session directly. Now we'll have the third session, which is diabetes in pregnancy, myth and facts.
Assalamu alaikum. Great. So my task is to go through some facts and myths regarding the gestational diabetes. And let's start with some truth about gestational diabetes, is that it is the most common medical complication that occurs during pregnancy. And the IDF has published estimation about the prevalence of diabetes of gestational diabetes the last few years, and it basically showed that, well, overall, globally, it's about 14%, but you look around different parts of the world, you'll find different prevalences. However, the highest seems to be in our region and in Asia as well. Well, while I'm not going to be covering pre-diabetes or pre-existing diabetes in pregnancy, but it's worth looking at the prevalence of these conditions as well. It's estimated globally to be about 0.2% of the pregnancies have either type 1 or type 2, whether newly detected or pre-existing or pre-known. But again, there is a wide variation around the globe, and in our region, it's actually twofold or actually tenfold as much as the global prevalence. And in Qatar here, we have a diabetes in pregnancy program incorporated with primary healthcare particularly, and some private institutes as well. And in this, we aim to screen every woman who does not have a pre-existing diabetes. And there is a screening program that starts as early as the first visit. And last year, we examined the data in about 120 deliveries. And what we have found here that in Qatar, we're able to screen 84% of the eligible women. I have no time to go this, but this is one of the highest in the world. And what our screening have shown us that 31% of the women have actually gestational diabetes, and another 5% have pre-existing diabetes, whether newly detected or already known, making overall about 36-37% of all pregnancies will have a form of diabetes in Qatar. Now, let's move to a myth here. And the myth is that the effect of gestational diabetes disappears after pregnancy. And the truth is, that's not the fact. So diabetes in pregnancy impacts both the woman and the offsprings or the fetus in different ways. The biggest complication or the highest or the most serious complication is the high rate of preeclamptic toxemia or PET, but as I'm going to show you later on, this seems to be more a problem with weight and excessive weight gain rather than glucose per se. And for the fetus, the biggest thing is the macrosomia enlarged for date, which has other consequences as well. But what we all know right now that those women with gestational diabetes after delivery, they're still at a high rate of developing all forms of the metabolic syndrome, including metabolic diseases, including type 2 diabetes, and that these offsprings as well are at high risk of developing type 2 diabetes at a younger onset, which we already have seen affects a lot of people in our area. And the most systematic structured study to date was actually back in the 90s that examined and followed women with OGTTs on annual basis for 5 years. And over 5 years, and that's what we usually refer to, we say 50% of women with GDM will progress to type 2 diabetes in 5 years. But what's critical to point out is the critical window of intervention is actually early on, because most of the diabetes seems to happen in the first 2 years. And globally now, a recent estimate that there is a wide variation in the progression of type 2 diabetes depending on the population, but overall, globally, it's about 10% per year. And for the offsprings, the most comprehensive long-term data came from was in the Pima Indians, and which shown that offsprings born to mother with gestational diabetes, and by the age of 30, 1/3 of them will have developed type 2 diabetes. However, the story is more dire when you look at women as offsprings born to a woman with type 2 diabetes. Almost 2/3 of them will have diabetes by the age of 30. And we currently understand the importance of the intrauterine environment in shaping the metabolic risks. We know that anything that can reduce the growth of the baby, causing small for gestational age, and that still includes some of the metabolic problems, which is obesity and excessive gestational weight gain leading to preeclampsia, or anything that increases the weight growth or the rapid fetal growth. So that causes small phosphatase or large phosphatase, these two phenotypes actually is associated with a high risk of metabolic disease in the future. So what happens in the environment, though, actually controls even the appetite regulation of those offsprings. We also get to know recently, based on a recent study that published this year in Diabetologia, that has probably the longest cohort, about 18-year birth cohort, was followed of a mother and offsprings, about 500 pairs, which basically showed that the glucose, the OGTT glucose, maternal glucose, correlates strongly with the offspring glucose OGTT data about 18 years later. And there's a lot of data in this study that I cannot cover because it's very extensive. But what is critical to take home from this study is that the glucose data correlates with the risk of obesity and overweight in those children. They've done a lot of modeling here, which we don't have time to cover and criticize. So the next myth here is that GDM affects only women with obesity. And in the next few slides, I'm going to bore you not with glucose, but with lipids. And I hope you did not skip or skim over your lectures on lipids metabolism, because it's very critical to point out that the changes that happen during pregnancy should be deeply understood when we're managing diabetes in pregnancy. The start of the pregnancy, there is, in the first part of the pregnancy, there is a general move towards building more fat storage in order to help fuel the growth of the fetus later on. So for this to happen, the mothers are actually hungry all the time. And there is an increase in insulin sensitivity, so they're eating more, and there is an increase in insulin sensitivity. That upregulates an enzyme known as lipoprotein lipase, and this helps the process of lipogenesis, building more fat. At the same time, the body, the peripheral tissue, which are the muscles, will stop using free fatty acids, and they will only focus on using glucose. All the fat is focused towards building fat storage. Now, things will change by 16 weeks onwards, and I'm going to show you why 16 weeks. And at that point in time, the placenta will start to produce more hormones that causes insulin resistance. And insulin resistance basically causes the following. It inhibits this enzyme, lipoprotein lipase, so no more lipogenesis, or lipogenesis is reduced, but we're going in the process of lipolysis, producing free fatty acids and glycerol. At the same time, peripherally, the muscles will now shift from using glucose, or be prevented from using glucose, to start using free fatty acids as fuel, in such a way that all this glucose is now be presented to the fetus in order to grow. The liver will start to use the glycerol in order to produce more glucose, and the free fatty acid, as I said, will be utilized preferably by the muscles. But too much free fatty acids is toxic, so the body re-esterified it into triglycerides and LDL. And the triglycerides levels actually mimic this story. Triglycerides start to increase by the age of, as early as 16 weeks. It plateaus by 35 weeks, and then the rate of increase will actually reduce a little bit. And triglycerides plays the most critical role in the size of the fetus. So the correlation, as I'm going to show you, between the fetus size and the blood glucose is very low, but is very weak, but there is a strong correlation between these triglycerides levels and the fetal growth. And the level of the triglycerides goes down, increased by about 2 to 4 folds. And the higher the insulin resistance, the higher are these levels. And I kept saying it's about 16 weeks. Why 16 weeks? Because that's the time the baby starts to grow and put on a little bit more weight. And the rate of growth peaks between 28 to 35 weeks and plateaus after that. And the triglyceride levels mimics exactly this level, these levels. I'm going to take you back a little bit to understand the pathogenesis of GDM by looking at type 2 diabetes per se. Because Roy Taylor has put forward a theory about the fat spillover theory, where he basically said that we have a certain capacity, genetic capacity, to store the fat in the subcutaneous tissue. Once this capacity is being exceeded, the fat will start spilling inside the internal organs. And what happens here, it starts spilling on the liver, causes insulin resistance. What the liver is going to do is take all these fats, turning into very low density lipoprotein, and circulate around in a form of triglycerides that get deposited all around, but particularly in the muscles and particularly in the beta cells, and cause beta cell failure. And what he did show or proposed that if we got the weight down, we're going to reverse this process and we go into the remission of diabetes. And he did do a study that I'm not going to touch now called the direct study. But the interesting part here was as a proof of concept that it's not the weight, it's the fat. He actually enrolled a group of patients who were people with type 2 diabetes who are not obese. And they have type 2 diabetes. And he got a matched group of people who are same age, same gender, same weight. And they put them on a program to lose 10% of their body weight. Initially, they measured the liver fat, and you can see that the liver fat was initially much higher, VLDL was much higher than the control group, and the triglycerides were high as well. Going through the same program of aiming for 10% weight loss, that's what happened to their glucose. They achieved remission from diabetes. Concurrently, the liver fat, VLDL, and LDL went down. So it's not the weight, it's the ectopic fat deposition, and it is the free fatty acids. Again, I'm reiterating that the free fatty acids on a long-term basis can cause peripheral and central insulin resistance. And on acute phases, they can stimulate insulin production. However, chronic high level of free fatty acids is actually toxic to the beta cells. And I already told you about triglycerides. Triglyceride levels correlates with the risk of GDM regardless of the BMI. The higher the triglyceride levels, the higher the risk of gestational diabetes. And women with gestational diabetes, their triglyceride levels is elevated 10 weeks before the diagnosis. So it's not glucose, it's a metabolic process that's gone on that's leading to the high glucose. And triglycerides correlates well with the fetal weight more than the maternal glucose per se. And triglycerides per se, as I told you, can increase and worsen insulin resistance and insulin secretion. Essentially, we have 5 main group of people who develop gestational diabetes. The root is common. It's insulin resistance leading to high level of free fatty acid, triglycerides, more insulin resistance, and beta cell failure. A group of women who will have impaired glucose tolerance or impaired fasting glucose, particularly impaired fasting glucose, those women will start the pregnancy with a high glucose, and you can detect them if you screen early in pregnancy. A group of women who have high body weight, high visceral fat, already high triglycerides. These early changes that happen as early as 16 weeks tips their blood glucose over, and you can detect them by screening early in pregnancy. A group of women who are obese or overweight, who balancing everything is fine, but they gain too much weight early on, they start spilling their fat inside their internal organs, and you start to have glucose, affect their glucose hemostasis. You can have lean people with high risk of metabolic syndrome as well. Those patients who have high visceral fat, but they're lean, like we see them, polycystic ovary, strong family history of diabetes, and the small changes, early changes in pregnancy can tip them over, and you can detect them by screening early. Or they're lean, but they gain too much weight. And again, you can detect those by screening for diabetes later. And from the data that we have, we're just yet to publish this data, you can see that there's a dose-response relationship between BMI and gestational diabetes, but still, in those we consider them to have a normal BMI, about 28% of them still have gestational diabetes. And if you add all forms of diabetes together, excluding type 1 diabetes, you can say 1/3 of the women here in Qatar who normal BMI still have diabetes, gestational diabetes. And there is a very strong epidemiological data linking the BMI with the risk of gestational diabetes and the excessive gestational weight gain with the risk of gestational diabetes. So another myth now is that universal screening is not warranted, it's not cost effective to detect gestational diabetes. And the truth is, people have tried this for a long period of time, and they did show that selective versus screening, that you're gonna miss about a quarter of the women with gestational diabetes, because a quarter of them don't have risk factors, as I told you. In the United States, they found that some studies found that selective screening is very cumbersome, and you only reduce the number of women, or the percentage of women need to be screened by 10%. Same data came out from other countries showing that up to 40% of the women, if you do apply selective screening, gonna be missed. And there's certain data from France moving from selective to universal screening showing a reduction in the rate of complications. And let's take you over here in our experience with the universal screening that happens as early as the first maternal visit. our data have shown that the outcomes of women with gestational diabetes approximate those with no gestational diabetes. In actual fact, there was a lower rate of IUFD in women with gestational diabetes. But the differences really between all of these is small, so that's why I use the term approximate differences. Because the rate of preterm delivery, the rate of cesarean section, macrosomia, large for date, all are pretty much similar. There's small percentages here and there with the universal screening. But we also have previous data that used selective screening back in 2011. And while the gestational diabetes prevalence has increased, you can appreciate a sharp drop in the rate of stillbirth between 11% to 0.35% with universal screening. Macrosomia rate is halved, preterm deliveries or as well has been halved in women with gestational diabetes. Even it's universal screening that we used to do just within one institute, which is the WWRC, not globally, higher prevalence, but also complications rates is going down. So universal screening, which is being embedded within primary healthcare, seems to reduce the rate of complications in Qatar. Now moving to a truth here, that diet is the cornerstone of the management of gestational diabetes. I've already shown you that maternal obesity or BMI correlates with the risk of GDM. And if you want to look at certain outcomes in pregnancy, this is a data from the HAPL trial where they screen women for gestational diabetes, but they were never treated or the physicians never know, and they follow them up. And what this data have shown is that if you take women with no gestational diabetes and no obesity as your reference, and then you look at the rate of certain complications, the rate of large for date, C-section, and preeclampsia are significantly, this is our hazard ratio, are significantly increased in women with obesity and no gestational diabetes. Now, if you look at women with gestational diabetes, only large for date is increased, but the rest of the complications persisted. And if you combine them, as you'll expect, the complication rate shoots up. The other part here is that excessive gestational weight gain is an underappreciated risk factor. I told you how too much weight gain can tip off the balance during pregnancy, especially it's happening rapidly in the first 20 weeks. And the meta-analysis have shown exactly that, high risk of PIH and PET, preterm labor, and large for date. And if you want to put things all together, this study actually looked at almost 1 million deliveries. At the bottom here, you will find the different weight categories. And then in blue are the rates, and these are the rates of large for date. Those are a group of people, women who have no diabetes and no excessive gestational weight gain. You can see just obesity, there is a dose response increase in the rate of large for date. Now, if you look at women who have no diabetes but gain too much weight, you can appreciate that the risk of large for date is doubled in most of the categories. And if you look at GDM and adequate gestational weight gain, you can appreciate that it's similar to excessive gestational weight gain in most of them. If you combine them, then you will start to see more and more complications. So can we do anything about it? I think the aim when we manage women with gestational diabetes is always to monitor and control the gestational weight gain. And particularly once GDM is diagnosed, some will advocate that you need to stop any more gestational weight gain. And some data from Denmark have shown that this is possible, and when we're able to do that, we reduce the chance of large for gestational age, which I just told you has a metabolic sequelae on a long-term basis. The last myth is that insulin is the only pharmacological treatment that we can use for GDM. And the truth is, metformin is as good as insulin in most of the cases, if not better, based on some meta-analysis which compared metformin with insulin, showing lower rate of macrosomia and lower rate of large for gestational age. And in a recent one, meta-analysis that we collaborated with Professor Doi from Qatar University, we have shown similar results. We have shown that there's a lower rate of maternal hypoglycemia, lower rate of large for gestational age, and lower rate of excessive gestational weight gain. And metformin is endorsed by many societies. NICE guidelines use it as the first-line therapy. Canadian guidelines endorse him as you can choose between metformin and insulin as first-line therapy. Society of Maternal and Fetal Medicine. FIGO, you can choose between metformin, sulfonylurea, or insulin as a first-line therapy. Only the American College of Obstetric and Gynecology and the ADA don't recommend it unless insulin is declined. But there is an important thing here to take into account, that when there is an issue with the placenta, we don't use metformin. When there is an intrauterine growth retardation or preeclampsia, which are all issues with the placenta, metformin, we avoid metformin or we stop metformin at this point in time because it seems to exacerbate the rate of small for gestational age. So I hope I've stuck to my time, Mr. Chairman. So my key takeaways here is that gestational diabetes is common. In Qatar, 31% of the pregnancies have gestational diabetes. And the risk factors are mainly pre-pregnancy obesity and excessive gestational weight gain. Universal screening can identify women at risk. I am an advocate of an early screening based on what we know. It's cost effective, and as I've shown you, it did reduce the rate of pregnancy complications. Dietary management is the key, is the cornerstone of GDM, of management of diabetes during pregnancy, with an aim that you have to aim as controlling or reducing excessive gestational weight gain. And as I've told you here, the story doesn't end by the delivery. It actually could be the start for all of them, the mother and the offspring. GDM has a long-term sequelae for both mothers and offspring. Thank you.
Thank you very much, Mohammed, for such enlightening presentation. We'd like to have a quick interaction from our top distinguished faculty, Prof. Schwartz, and then after that, we move for 10 minutes break.
Thank you very much for the opportunity. It was very interesting to listen to the presentation with gestational diabetes. There's one aspect we should not forget, and this is type 5 diabetes. You may have heard that in Bangkok, we started a scientific working group to develop the type 5 diabetes, and there's a lot of attention worldwide to type 5 diabetes now. And why I'm saying this? Because often the mothers first get obvious with diabetes, with gestational diabetes, but they actually have a type 5 diabetes. And this is depending on a maternal malnutrition or maternal protein malnutrition of the mother during the pregnancy, and then the offspring is getting diabetes. And if this is a daughter, it's often gestational diabetes. And the connection is often that due to protein malnutrition, there are only 50% or 40% of the beta cells developed in the daughter. And so this is something beside obesity, beside weight gain, beside all the risk factors mentioned, also may contribute to the prevalence, the rising prevalence of gestational diabetes worldwide. Thank you very much for this very interesting presentation. And I would say it makes sense to eat protein to prevent gestational diabetes.
We'll keep the questions to Dr. Mohammed as well as to Dr. Rishi to the final panel discussion. We'll break now for 10 minutes and then we will reconvene here for the final part of our STEPS program. Thank you very much all. Thank you. Assalamu alaikum. Welcome back after a very quick break. And the STEPS program is marching on. I will just hand over the center stage to my co-chair to introduce our next distinguished speaker. Yes.
Thank you, Dr. Tariq. Now we'll have the fourth session after refreshment from the break. We will have the living with diabetes, navigating life with care, obesity, early years in diabetes. Will be presented by Dr. Amin Jayousi. Dr. Amin is a senior consultant of endocrinology and diabetes at Hamad Medical Corporation and is associate professor at Weill Cornell Medical School, Qatar. Welcome, Dr. Amin.
Thank you, Dr. Yasser. Assalamu alaikum. I will try to be as short as possible because of short of time. I am supposed to thank the organizing committee as well as the Merck Pharmaceutical Drug Company and all the attendees and participants for this meeting. My talk is about living with diabetes, navigating life with care, control, obesity, early years in diabetes. Simply, somebody who is having a new onset of diabetes and with mildly uncontrolled. There is nothing to disclose from my side. And here is a fourth family member. As you see, he is 55 years old, male, diagnosed with type 2 diabetes. A1C is 8%, no cardiovascular disease, mild hypertension, no hyperlipidemia, and his BMI is 30, which is on the overweight to obese side. Now, our aim is to control this patient A1C and to get it down to around 7%, because it is uncontrolled, about 8%. Now, this is the omnious octet. Omnious octet is the pathophysiologic defects that might lead to hyperglycemia. As you see, if we start with the pancreas, we have the decreased insulin secretion from the abnormality of the isolate beta cells. Also, the increased glucagon secretion from the isolates gamma cells of the pancreas. There is a defect in the liver where there is increased hepatic glucose production. In the intestines, decreased incretin effect, increased lipolysis from the fat cells. Also, there is increased reabsorption of the glucose at the level of the kidneys and decreased glucose uptake at the level of the muscles. And there is polyphagia, which is the neurotransmitter dysfunction at the level of the brain. These patients with diabetes, they are becoming polyphagic, polyuric. They like to eat more. I feel I need to eat more, doctor. That's why I have diabetes. This is put forward by Inshuzi, as well as our friend Ralph DeFronzo in USA in 2009, and it was updated in 2011. Anyway, just remember, 8 steps explain the hyperglycemia occurrence. And if you want to ask, are we able to control diabetes? In Qatar, we don't have except 35 to 37% controlled. Take it from me. I am the father of diabetes in Qatar. Here, if you see in the United States, the top-notch people, 49.1%, they are not controlled. Their A1C is more than 7%. If you take the panorama study in Europe between 2009 and 2010, look, almost 35% or more, they are uncontrolled. And even in UK, as you see, almost 40%. So uncontrolled diabetes is everywhere, whatever where you are working or living. Now here is just to show you the omnious octet, how to counteract it. These pathophysiologic defects leading to hyperglycemia, what medicines, whether tablets or injections, to control or to take care of this hyperglycemia. We have the sulfonylurea, the GLP-1, the DDP-4 work at the level of the insulin release from the pancreas, and on other sides as well where the incretin effect, it affects as well the, if you look for the GLP-1, for the appetite. Our problem here in Qatar, we have overweight or obesity. Just to remember this percentage, 70% of people living on the earth of Qatar, they are either overweight or diabetic or obese. 44% of women in Qatar, they are obese. 40% of men in Qatar, they are obese. And there is the other medicines like the DDP-4, which is a mild anti-diabetic agent. Tablet can lead to 0.5% or 0.6% in the best scenarios, reduction of A1C. It works at the incretin level. We have other medicines, which is the old one, which is the sulfonylurea, which is good for reduction of A1C, take care of the glucose level, but the patient will pay, as well as the physician, the disadvantages, which is the increased weight, and the hypoglycemia which can occur with these agents. Now, the first line treatment, metformin. If you want me to talk about metformin, I will talk till tomorrow morning, but Dr. Tariq asked me to be very short. Metformin is our old friend since 1957, in the last century, and it has been used frequently as the best medicine to start with. And all the guidelines, whether in the East, in the West, in America, in Europe, they say still metformin is the first line to be used. Why the first line? As you see, this is very busy slide, just to remember that if you look for the action of metformin at the level of to treat diabetes, it will work, decrease at the level of the liver the gluconeogenesis. The formation of glucose at the level of the liver will be decreased. Also, at the level of the muscle, it will stimulate the glutathione 4 and will lead to increased glucose uptake by the muscles. What about intestine? It will increase the GLP-1 as well as the microbiota dysbiosis, which is very important for the control of sugar. If you look for metformin, it has been mentioned in the morning in the earlier speakers that it works at the cancer, take care of obesity, also aging, renal disease, cardiovascular disease, liver disease. It is a medicine, fortunately, helps everywhere to treat our patients. Now, how is the mechanism of action at the level of the stomach, of the GI tract? It leads to decreased glucose absorption from the GI tract, increased glucose transport from the blood to the gut, lumen, increased glucose utilization by the intestinal cells, increase the GLP-1 secretion, as well as modulates the gut microbiome. Metformin is a golden tablet, and it is very important to remember that it has some benefits. If we look for being a tablet, it's easier than an injection. Also, it has high efficacy to take care of the glucose level. There is no hypoglycemia. Patients are telling me, I am taking metformin, maybe I am having this feeling or shivering, whatever is it to do? I say no, metformin does not cause or induce hypoglycemia. We have the weight effects. It is not a weight-losing medicine. I put this in the 80s in the newspaper. Metformin is not a weight-losing medicine. It has not been put in the guidelines by the USA, whatever, or ESD about as a weight-losing medicine. It's not. It helps maybe in the best scenario 2 to 3 kilos weight loss, but not a weight-losing medicine. Now, what about the effect on the heart, cardiovascular? It is beneficial, potential benefit for the MACE, but not, it is neutral for the heart failure as well as the CKD. Remember, any patient who is a cardiac patient, who is following the cardiac or heart hospital, having shortness of breath or heart failure, don't prescribe for him metformin. What about the other considerations? When to use it with patients with diabetes, their EGFR, or 40% of our patients, diabetics, they have chronic kidney disease. These 40%, you have to be careful. Look at the EGFR. If the EGFR is 30 ml per minute or less, stop metformin totally. If EGFR less than 60 down to 45, put 50% of the dose, which is 1,000 milligram. The total dose for diabetes, how much? 2,000. For pre-diabetes, 1,500 milligram. Now, if somebody who is having chronic kidney disease and diabetic, EGFR between 45 and 30, we give only 25% of the total dose, which is 500 milligram of metformin. Now, the only thing I want to remind you about metformin, all these benefits, one should think how to use it gradually, not to give the total dose at the same time, because patients will have the GI side effects, which is nausea, vomiting, bitter taste, sometimes constipation, sometimes diarrhea. Don't be like that. Try to ask the patient to take it with food or after food, and to start with 500 milligram, small dose, for about 4 days, and then to upgrade and titrate till you reach to the upper normal dose. Now, when to use it? The guidelines mention that metformin can be used in combination if the A1C is 8.5% or more. From the beginning, combination therapy is better than using metformin alone. Also, if the patient is having A1C more than, which is almost the same, 1.5% more than what you want to reach as a goal, which is 7%, this is 1.5% more, which is 8.5%. Start with combination, early combination therapy. Don't be, this clinical inertia. Today we'll start lifestyle, diet, exercise. All my speakers in the morning talking about this, but it is really impossible. Patients are not. You can bring the water to the camel, but you cannot force the camel to drink it. Patients are not listening. They are overeating. This talabat, sunun, or rafiq, whatever, I don't know, in the streets. So overweight, obesity, big problem. So you have to ask the patients to try to take the medicines and to take care of lifestyle if possible. Now, look at this. Just to remember that metformin will take care of A1C about 2%, which is very good. Sulfonylurea about 2%, but what is the difference? Sulfonylurea can induce hypoglycemia. It can increase weight, and it does not have any renal or cardiorenal protection. Now, what about the metformin being used? This study showed that if you start with metformin, these patients will not be in need to use other medicines till further time. Only 24% of these patients using metformin need other medicines, while if you look for the other ones, sulfonylurea, TZD, DDP4, higher percentages. It is a good lasting medicine. It has a long, duration of action. Now, this is a study showed that more than 3,000 people with type 2 diabetes diagnosed, and they were given the metformin. What were the results? Look, 7 out of 10, they achieved the control. And 6 out of 10 who were A1C baseline more than 9%, which is the highest, they got achieve control. Something to remember, the higher is the baseline of A1C, not only with metformin, with all other medicines, the higher the A1C baseline, the medicines will give you a better benefit. If I have 2 patients, one who is A1C is 10%, and somebody who is having 8% or 7%, if I give any medicine, the A1C reduction will be higher with the one with baseline 10%. This is just to show you that hemoglobin A1C, starting with the low dose, then titrate to 1,000, 1,500, 2,000. 2,000, how much it will give? 2% A1C reduction. It is titrated. It is related to the dose. And to remember that it's not only A1C reduction, but also fasting blood sugar. So anyone in your clinic who is having impaired fasting or high fasting level, start with metformin and up titrate, and it will give you a benefit up to, with the highest dose of 2,000 milligram, how much? 80 milligram less of fasting blood sugar. So somebody who's 280, it will give you, after that dose, down to 200, less than 80 milligram for the fasting blood sugar level. Look at this, just to show you that from what is related to the dose of the dose of metformin used, the A1C reduction will be. And here, this is a small dose of metformin showing little reduction of A1C. Look at the middle, higher, and at the last, there is a connection where higher A1C reduction, and it showed that the maximum reduction of A1C was maintained at around 7 months after use. It takes some time and continued and was maintained up to 12 months. So it is It starts after a few months and continue for a longer duration. What is the difference? Always patients are asking, what is the difference, and doctors, difference between the immediate release metformin or glucophage IR and the glucophage XR or SR? The extended release or slow release and the immediate. The previous one, the old one, is the immediate. What is the difference? The new one, SR, extended release, they put a gelatin capsule, they covered it like that, and they encapsulate it. Why? To show that the absorption will be slow and the duration of action will be longer. Look at the blue color. The blue color is the new one, the SR or XR. The absorption was slower and longer duration, while the previous one, with the same dose, it is the immediate release. It will be sudden and instant action, but for less time of duration of action. So the new one is much, much better than the older one. The main thing that you should remember as a physician, patients are asking you, in addition to this difference, there is patients who are taking the immediate release, the previous old type, glucophage or metformin IR, they cannot take it at the same time all the dose because this is short duration of action. It acts only 8 hours or 10 hours. The slow release or extended release can be given divided or the whole total dose at the same time after patient is used to this medicine. So you can take the whole dose after you get it trained for it and escalating the dose at the same time, and it will cover for 24 hours. This is just to show you that treatment adherence with metformin. Metformin is not causing problems if you use it in the right way. There will be no problems and patients will be attained and they will take it for longer time. And as you see, if you take it for longer time and you are adherent to the medicine, it showed that those who are adherent, as you see in the green, in the blue, they are much having a prevention of problems like what? Hospitalization due to stroke or MI hospitalization. It helps because patients are taking it and there is no problems. They are adherent to it. Now, the second line treatment, if we use metformin and we don't reach for our target, there is the DDP4 inhibitors. It is a tablet form, and the mechanism of action is that whenever we take food, there will be release of what? In the small intestine, GLP-1. And there is an enzyme called DDP4 enzyme. This enzyme will cause the GLP-1 obstruction. If you inhibit the obstruction, you will get a benefit of the GLP-1 will be in a higher amounts and it will lead to stimulation of the insulin secretion and suppression of the glucagon. This is the way that the DDP4 tablet acts. Now, if we combine metformin with DDP4, as you see here, in the blue color, the metformin and the vildagliptin at the same time, galvasmet, it will give you a better action and for longer duration of period, about, as you see, 62 months compared to if you use metformin alone to only 36 months. So combination therapy always much better. And then this is the other class, which is the SGLT2 inhibitor, where you know that it is causing inhibition of reabsorption of the glucose at the level of the kidney. There, in normal persons, they don't have diabetes, there will be no glucose. But in somebody who is having diabetes, there will be glucose. And if you inhibit this by SGLT2, this is a novel therapy, it will show that more glucose will be excreted from the kidneys down through the urine. And you will have glycosuria. It works as a diuretic. And it has a beneficial effect of cardiorenal protection. This is the GLP-1, which is an injection Everybody is asking about this, and we have different types of it, as you know, semaglutide, liraglutide, exenatide, weekly and daily injections. We have the Mounjaro. Everybody in Qatar is asking Mounjaro. The mechanism of action, it increases the insulin release, decrease the glucagon, and the gastric emptying will be slowing of gastric emptying, blocking the appetite. Appetite is becoming less, and there will be decreased food intake or appetite. The sulfonylurea, I mentioned it already, that stimulates the secretion of the insulin from the pancreatic cells, and the sulfonylurea is the same as خلاص. Thank you very much. I will sit down. If any question later, anyone can. No problem. Thank you, Dr. Tariq. Thank you, Dr. Yasser.
Thank you.
Shukran.
Thank you very much, Amin, for such wonderful presentation. Peter, the floor is yours.
It was fascinating to listen the father of diabetes from Qatar. And it was very clearly pointed out, if we really want to give the patient metformin, then I always would recommend actually two things. The one is, if you use immediate release metformin, don't give it as metformin, give it as metformin, so that the patient is taking it in the evening. If they are going to bed, they take the pill, because then they sleep over the potential side effects. But XR is actually much, much better, and it was very clearly stated. By the increase of adherence, you lower the A1C significantly. And if you give XR metformin, this is the best you can do for the patient. And the combination of metformin with anything else what we have in diabetes care is a very cool combination. So this is also something we should have in mind. So thank you very much to the father of diabetes in Qatar. I apologize that I cannot be in person. Thank you personally. So shukran for this excellent presentation.
Thank you very much, Professor Schwartz. Now we'll have the fifth session. For the sake of the time, unfortunately, it will be recorded because Professor Riaz has certain circumstances and couldn't attend. The fifth session will be Living with Diabetes, Navigating Life with Care, Cardiometabolic and Renal Consideration. It will be about the cardiometabolic and renal consideration in patients with type 2 diabetes. Will be presented by Professor Riaz Malik. Professor Riyad is a professor of medicine at Weill Cornell Medicine Qatar and the University of Manchester, UK. He is also senior consultant of endocrinology at Hamad Medical Corporation. Please start.
Assalamu alaikum, everybody. I apologize for not being there, but I am at a pre-ESD meeting, the NeuroDiab meeting currently. However, I am going to give my lecture, which is entitled The Final Step. These are my disclosures. And the patient I'm going to talk about is a 61-year-old patient with type 2 diabetes for 11 years. Current treatment, sitagliptin, metformin, gliclazide, and lisinopril and atorvastatin for other cardiovascular risk factors. His weight is 96 kilograms. However, HbA1c, as you can see, is not well controlled, 9.2%. Blood pressure is also elevated, 148/93. EGFR is reduced, and there is evidence of proteinuria. In addition, blood tests show that there is actually evidence of fatty liver, and in combination with the platelet count, a FIB4 score confirms risk of fibrosis. Because of the weight, or perhaps other reasons, difficulty sleeping, but also difficulty sleeping because he also, in addition, has pain and numbness in his feet, which nobody's asked him about. And occasionally he does get some hazy vision, but he says it's intermittent. And he also has reduced exercise tolerance, ankle swelling, with a pro-BNP of 2,200. So, what do you do with this gentleman? First of all, At this stage, I'm going to ask a bold question. Can we cure him? Can we cure him of his diabetes? Perhaps not some of his other comorbidities, but perhaps the diabetes. His weight is 96 kilograms. HbA1c is 9.2%. Well, if you'd asked me this question maybe 5-6 years ago, I would have said no chance unless the patient undergoes bariatric surgery. But it's no doubt that being overweight is a clear risk factor for developing diabetes and then obviously having diabetes. But from an excess of fat, diabetes begins, and from an excess of fat, diabetic patients die. And indeed, in a recent systematic review and meta-regression analysis, together with colleagues from Cornell, we looked at all the evidence, 22 publications in total, which have tried to address this in terms of the simple question: if you lose weight, then can you undergo remission of diabetes? And we had two definitions, and we were limited by the definition. I believe actually a true remission is at HbA1c less than 5.7%, but the literature previously had really looked at complete remission with HbA1c less than 6% and partial remission with HbA1c less than 6.5%. What did we show? Well, basically, if you lose weight, you will have a chance of either complete or partial diabetes remission. And the more weight you lose, the higher your chance. So if you lose less than 10 kilograms, really your chances of complete diabetes remission are almost zero. Whereas if you lose, say, 5.5%, which a lot of people would say, well, that's good, then you get partial diabetes remission about 5.4%. However, if you get to the higher levels, which is 10 to 19, 20 to 29 kilograms, particularly more than 30 kilograms, then you really have a 79% chance of complete diabetes remission, 89.5% of partial diabetes remission. Previously, of course, this was only achievable with bariatric surgery, and also there was a thought that maybe it depends on duration of diabetes, the age, but in this analysis, actually, we showed that the benefits are independent of age, diabetes duration, starting HbA1c, starting BMI, and also the type of intervention, because this included not only people with bariatric surgery, but also on therapies. What therapies could this be? Well, actually, this is a quote from Charles Dickens. It was the best of times, it was the worst of times, it was the age of wisdom, it was the age of foolishness. What do I mean? Well, in the past, perhaps it wasn't the best of times, certainly for diabetes remission, because we had insulin. What does insulin do? It's going to treat the glucose, but it certainly isn't going to put you into remission. We do have drugs like biguanides, which do have a small impact on weight, but really no more than, say, 5 kilograms. And then we have lots of other drugs that have come through, actually, particularly the GLP-1 agonists, which are now, I believe, are an effective therapy for in good weight loss and perhaps remission of diabetes, particularly the long-acting GLP-1 agonists and the GLP-GIP and perhaps the triple agonists. So, what do they achieve? Well, I could have taken data with semaglutide, but this happens to be tirzepatide. But all the trials show that there is a significant weight loss. Perhaps not as good as bariatric surgery, but nevertheless, if you look in the red column, you can see anything up from, say, 9.5 kilograms being the lowest to 12.9 kilograms in SURPASS-3. So patients who are treated with diabetes, actually even without diabetes, do get weight loss. They also get a large reduction in HbA1c, anything from 2 to 2.59%. And diabetes remission, as I would say, real remission, which is HbA1c less than 5.7%, you can see across the board up to 50%, up to 62% of people achieve diabetes remission. So in this case, maybe, just maybe, we might be able to achieve that. But what about other things that are going on in this patient? Well, we know that he's got metabolic associated steatotic liver disease based on the ALT, AST being high, platelets being low, and a FIB-4 score of 4.82. There are data showing that from SURPASS-3 actually, with tirzepatide compared to insulin degludec, that there is a impact on liver fat. Indeed, liver fat, baseline 27.3%, LFC at week 52, 2.6%. And if you plot that out, you can see progressively there is a reduction, although not really, you would say, a dose-dependent effect, but nevertheless, all doses, even the 5 milligram dose, reduces liver fat compared to insulin degludec. So can we improve his heart failure? Yes, with therapies for heart failure, but perhaps with the therapies that we might use for diabetes. Reduced exercise tolerance, ankle swelling, he's got pro-BNP of 2,200. What does that mean? Well, actually, based on the pro-BNP, you can see that he is really high risk. He has a level over 2,000 picograms per mil. He has heart failure, very high risk. Priority is echocardiography and evaluation by a heart failure team within 2 weeks. Is there data to say that patients like this might benefit? Well, there is. The Summit trial published last year, this shows that patients who are treated with tirzepatide compared to placebo, overweight patients, left ventricular ejection fraction actually preserved, but nevertheless with class 3 or 4 New York Heart Association heart failure, improved Kansas City questionnaire, cardiomyopathy questionnaire with tirzepatide, and improved outcomes, cardiovascular death, worsening heart failure, all significantly improved on tirzepatide by actually 38%. So can we improve his neuropathy? Difficulty sleeping, pain, numbness in his feet? Well, we actually have data from Qatar showing that exenatide once weekly, which is no longer available here, and pioglitazone or basal bolus insulin can, as one would expect, improve blood sugar control. So HbA1c, as you can see, fell from 10.4% down to around 7% in both arms. But in addition, using the technique of corneal confocal microscopy, we were able to show over 12 months that there is actually regeneration of small nerve fibers. And indeed, there is an improvement in fiber density, branch density, and fiber length in both arms, actually, both the insulin arm and the exenatide arm. In addition, now, there is actually a paper just published in Diabetologia which looked at the effects of metformin, whether that might have a benefit using corneal confocal microscopy in people with type 2 diabetes. And so what they essentially did is compared people who were on metformin compared to a group that were not on metformin. HbA1c, as you can see, was better by about 0.5% in those on metformin. But in addition, there were other differences. For example, in fact, there were no differences in DPP-4 administration or sulfonylurea, but they actually had more patients on SGLT2 on the metformin group, comparable GLP-1, but insulin use was lower. What did they find? Well, actually, corneal nerve fiber length was better in the patients on metformin compared to the non-metformin users and was more comparable to healthy controls. So corneal nerves better in those on metformin, and corneal nerve branch density, corneal nerve fiber density, which is again markers of the number of nerves there, were better in those on metformin compared to those not on metformin. We have also, with a collaborative study from a group in India, have shown actually that dapagliflozin could be beneficial for nerve fiber regeneration. Small study, but type 2 diabetes, randomized to either 10 milligrams of DAPA or standard of care. Both groups actually reduced their HbA1c by about 0.5%. However, we show that corneal nerve fiber density, corneal nerve branch density, and corneal nerve fiber length significantly improve in these patients over a period of 6 months. And this, we believe, is independent of actually the reduction in HbA1c. So there is actually an improvement in superoxide dismutase levels, so oxidative stress, and also glycation MDA levels were reduced in the dapagliflozin arm. What about his retinopathy? Because he was complaining a little bit of less clear vision. Well, actually, if you look at the evidence, is it this or is it just a blurring of vision? And we need to think about that because that could mean different things in a patient with diabetes. Is it a cataract? Is it some other problem like NAION? Or is it diabetic retinopathy? Well, for the current treatments of diabetic retinopathy, semaglutide, as you know from the SUSTAIN 6, I think, semaglutide suggested that there may be a worsening of diabetic retinopathy. However, that is only one study, and subsequent studies have not confirmed this. And in fact, the most recent data is published in JAMA Network Open 2025, a large retrospective analysis of TriNetX data essentially shows that in the entire cohort, maybe actually GLP-1 therapies still have a signal that the diabetic retinopathy could worsen. But as you know, this non-arteritic optic neuritis, there is a signal, but it's not significant. Other problems like blindness and neovascular glaucoma, no signal for GLP-1RA. For those with pre-existing diabetic retinopathy, which is always a concern, has been a concern, what happens to them if they put them on GLP-1 receptor? Well, actually, no significant worsening of proliferative diabetic neuropathy or macular edema, and in fact, neovascular glaucoma is reduced, and NAION is, again, no signal, but vitreous hemorrhage is lower, laser photocoagulation is lower, vitrectomy is lower, and treatment with anti-VEGF medication is also lower. So composite treatment outcomes, no worsening, and in fact, blindness is lower on those with pre-existing retinopathy. We, of course, await the results of a proper randomized study, which is the ongoing study with semaglutide called the FOCUS study, which will report in February 2027. There are, however, data with sodium glucose cotransporter 2 inhibitors and risk of retinopathy. This is again published in JAMA Network Open, where it compared SGLT2 inhibitor use with DPP4 inhibitors, with pioglitazone, and with sulfonylureas. So this is a large study from Taiwan. Cumulative incidence of sight-threatening retinopathy was lower in people on SGLT2 inhibitors by 38% compared to sulfonylureas, was lower compared to pioglitazone by 25%, and was lower compared to DPP4 inhibitors by 33%. So being on an SGLT2 inhibitor may be beneficial for diabetic retinopathy. Finally, what about nephropathy? Is got hypertension, EGFR is 58, and proteinuria. Well, the evidence is very clear for the SGLT2 inhibitors, and it's been around for a while. Large numbers of patients, big trials all show improved outcomes in terms of the things that matter, which is renal worsening, renal failure, renal death. Reductions by up to 44% in people with established cardiovascular disease and 46% in people with multiple risk factors. So there's no doubt SGLT2 inhibitors benefit patients. On top of maximal ACE-ARB therapy, there is now also data from the FLOW study with semaglutide on chronic kidney disease, which showed that people with EGFRs of 46, glycated hemoglobin reasonable, 7.8, you might say, and not particularly overweight. On maximal ARB or ACE, so you can see almost 100% was on it, but also on SGLT2 inhibitors in about 15%. However, when they go on this therapy, glycated hemoglobin does drop by 8.81% and body weight decreases by 4 kilograms. And systolic and diastolic blood pressure also improve. What happens in terms of renal outcomes? Well, in the semaglutide group, you can see compared to the placebo group, the change in EGFR over time is actually not flattened, but is better. So it's not as steep in terms of the progressive reduction in EGFR. And so the difference is actually about 1.16 mils per minute per year. And furthermore, First major kidney disease event, which is kidney failure, dialysis, transplantation, EGFR less than 15, greater than 50% reduction in EGFR, kidney rate of CV death was significantly better by 24% in the semaglutide group. Thank you.
Thank you very much, Professor Riaz, for this recorded session. Now we came to the final session of our symposium today. It will be how to combat the rising prevalence of diabetes. Will be presented by Professor Peter Schwartz, the current president of the International Diabetes Federation. Professor Schwartz is a professor of internal medicine and the head of the Department of Prevention and the Care of Diabetes at Technical University Dresden. Professor Schwartz will present this presentation online because he couldn't attend physically to Qatar, and inshallah I hope you will enjoy his presentation. Professor Schwartz, the floor is yours.
Thank you very much for this nice introduction. Salam alaikum. It's a great honor to speak here today, and I apologize again for not being there in person. But you can imagine, due to the attack 2 days ago, the insurance fees raised a lot, and the insurance and several people actually also from the ministry in Germany recommended to wait for some days. But I wanted to come, and I apologize for not being there. I just had during the session contact with some of the people in the auditorium. So it's heartwarming to experience this encouragement, this enthusiasm, this passion of you in improving the quality of diabetes care. The last statement, this is exactly what is driving me as president of the International Diabetes Federation, that we should see whatever gaps we can close, what barriers we can break, strategies in an innovative way we can adhere to improve the quality of diabetes care. And this is what I would like to touch in the final minutes with you. We had the STEPS program. The STEPS program at the end is touching this five personas of people living with diabetes or having diabetes or may having pre-diabetes. Something which is very controversially discussed at the moment. We just have a commission discussing the definition of pre-diabetes. It's a Lancet commission, and this is much undiscussed. Is pre-diabetes existing? Or is it an intermediate hypoglycemia? Or is it a metabolic dysfunction associated hypoglycemia? So there is a new nosology in diabetes coming up. What role plays insulin resistance in this field? Or is maybe pre-diabetes already too late? And also what is the 1-hour glucose level playing a role? Ralph Defronzo was mentioned. He talked about more than 20 years ago already about the 1-hour glucose level. And similarly, we have the same discussion about harmonizing the standards, how to diagnose diabetes. There is next week at the ASD a commission starting to touch the diagnostic criteria for diabetes, because they vary a lot worldwide. But we also had gestational diabetes, and we had early development of diabetes. This is what we are seeing on everyday practice. And the people at risk, we don't see them, unfortunately, but every relative of our patients is a person at risk. I mentioned the type 5 diabetes. These are people having lifelong very high risk of getting diabetes. The pre-diabetes aspect, gestational diabetes, early and advanced stages of diabetes. What is the reality worldwide? We just released this IDF 589 million people living with diabetes worldwide, but WHO is talking about 800 million. I highlighted already that we have a lot of different diagnostic criteria to diagnose, and now the 1-hour glucose is also coming in for diabetes diagnosis. It doesn't matter in Europe and North America because all the criteria overlap very well. But if you go to Southeast Asia, there is a disconcordance of the diagnostic criteria. So we cannot be sure how many people with diabetes live on Earth. But of course, the number is far too high, and we have to act to improve the quality of care. And several of the presenters mentioned it's a nutritional disease. It's a nutritional environment. Our eating habits, our lifestyle, at the end driving the prevalence of diabetes. Where live the people with diabetes? They come in 83% of the cases from India, China, Bangladesh, and Pakistan. Four countries, more than 80% of people with diabetes live there. So if IDF wants to have impact, we have to have the impact there. And there are challenging new information. We have to understand better where diabetes is coming from. You might say this slide shows you the increase in prevalence of diabetes in the upcoming 10 years. It is not. It is the conjunction of type 2 diabetes prevalence and increase in air pollution. If you go out of the hotel you're just in front of the hotel there is a, let's say a nice German diesel engine is running, and you take three deep breaths behind the diesel engine. 2 weeks later you find medium-sized particles out of the diesel engine producing better cells. Unfortunately also in other endocrine cells. So what does it mean for diabetes? We don't know. In cell culture that it impairs insulin secretion by 30%. So this is a determinant which was neglected in the last decades. But now think about it's maybe not Dubai or Doha. It's Mumbai, Chennai, and Delhi, which has or might have a problem. So a new determinant. But if we ask ourselves what is the main determinant for getting diabetes, and the answer is short: fried carbs. If you fry carbs at a temperature of above 130 degrees Celsius, and you build bonds between glucose and fat during the frying process, and we eat them because it's so tasty. But what happens? This bond between glucose and fat, they are very strong. The body needs a lot of energy to break them down. And there's no need for the body to do this because there's a constant influx on energy and carbs. That's why the body is storing this in the liver. This is the development of MASH and muscle. This is the development of accumulation of fat. If you now have in mind, if you have 100 fat in your liver, you become a non-responder for physical activity. You become a non-responder of most of our lifestyle changes, and a non-responder for most of our antidiabetic. The same for hypertension and lipid treatment as well. So the fat in the liver becomes a new devil, and we have to let's say eradicate or change this. But now imagine how difficult it is to change this lifestyle. If you are in India, this is the most common. Even if they are vegetarian, they fry the vegetarian food in a panade of chickpeas and corn. So this is something we should tackle if we talk about prevention again. Because the power of prevention is in this two numbers. Walking 10,000 steps from the age of 22 will prevent any chronic disease from developing. And similar as Dr. Malek has said, and the previous speaker, if you have diabetes and you are physically active, if you only walk 1,000 steps more than you normally do, it doesn't matter how much you're walking, every day 1,000 steps more. It lowers the post-prandial blood sugar by 1.5 millimoles. This is twice as much as 1,000 milligram of metformin are doing. So this is actually cool because physical activity is the cheapest anti-diabetic agent, and every patient has it in its muscles. But the reality is what the average German actually is walking. We are a very lazy species, and maybe we we should change this. Maybe we as colleagues should change this. If I ask the other way around, how many hours per day we are physical inactive, this is the number. We are a lazy species. But forget about it. We have to understand the pathophysiology because we are physicians. This is healthy. This is a young woman, high normal A1C, and she has a totally flat, even if she's eating a lot of carbs. And this is what we know today, based on CGM and 1,440 measurements a day. This is healthy, someone who's very insulin sensitive. But here is her father. The father is actually having a better A1C than the daughter. But you immediately see there's a different curve. You see an up and down into the hyperglycemic range of the glucose. And today we know the father is very resistant. So the father needs maybe 80% of its insulin to regulate blood sugar. The daughter only 1% of the insulin. And this difference makes a big difference for micro and macrovascular complications, for cardiovascular and kidney complications. And to normalize this is a future challenge in diabetes. The problem is we don't find them yet. We had the discussion in the first lecture about using CGM for lifestyle change. I fully recommend this. But I'm very hopeful that in 3 years from now, we will have sensors for less than $1 for 2 weeks. And this will disruptively change our ability to diagnose, to monitor, to support patients having diabetes, but also many others. We will learn more about cardiovascular risk from the glucose curve than from an echo. But the goal in the future is cutting the high and cutting the low values, because amplitude of fluctuation drives morbidity and mortality. Imagine two people have an A1C of 7. One has mild fluctuation, the other one has big fluctuation. One with a big fluctuation dies because of stroke and heart attack. The one with a mild fluctuation may not even need an intensive treatment. So this is the future of diabetes care. And here again shown, as we have seen in two presentations, the pathophysiology over 50 years of diabetes development. And there's a new player, and this is the already mentioned. And you see, about 80% insulin resistance. This is the stage of the father. The liver fat accumulates and then it goes continuously up. The daughter is somewhere about here. But this fat in the liver is today's devil. Because if we want to address this, we think about how to get the visceral and the liver fat away. But here diabetes starts and here we diagnose diabetes. So if you review today's session, we should think about acting more aggressively on insulin resistance, on visceral obesity, on liver fat. And the cases we just have discussed are those. The diabetes, the pre-gestational diabetes, and then the two cases of diabetes just at the diagnosis and later on. So this is a dysglycemic continuum of development of insulin resistance and diabetes. But the true interplay between visceral fat and hepatic fat drives the diabetes risk. And we should get them away. And the answer how to get them away on visceral fat is physical activity. But how to get the hepatic fat in the liver, between the hepatocyte? And the answer is fasting. If you fast for 2 weeks, total fasting with a prolonged ketosis, you mobilize the glucagon release, helping you to break down glycogen for 4 days, and then the same glucagon can break down protein to make glucose out of it. And this will happen if you fast and lay in bed. Then your muscle is broken down. But if you fast and you are physically active, walking 10,000 steps a day, then the glucagon breaks down fat to make ketones. And where is the glucagon? In the pancreas and the liver. And this is a cool message for the future of diabetes prevention and remission. And you have heard this in the last two talks about how weight reduction can foster remission of diabetes. And I think the more efficient, the fast way in my eyes is fasting. And this was shown from Taylor. If you have fat in the liver, you have it in the pancreas, it destroys better cell function. If you remove it from the liver and the pancreas, restore better cell function, and this is diabetes remission. Basically means moving the people back on the development of diabetes. Of course, we have treatments, and you have seen this slide. We have treatments who help the patient to lose weight or gain weight. We have treatments who lower A1C and have a different cardiovascular risk. But if we bring this together, all this and side effects on this slide, which is very easy to read. You see again the eight classes of drugs we have. Here you see all metabolic effects and side effects. Lowering A1C and then other metabolic effects and side effects. Cardiovascular effects and side effects. Green is good, red is bad, gray means we don't know. And now look at the first line. This is metformin. The coolest drug we have in the diabetes sector. But imagine you are my diabetes patient, and I come to you and say, I have a new treatment for you. It's the second line. Would you like to have this? Diabetes treatment increasing the cardiovascular risk for our patient, and this are sulfonylurea. But we also have other good drugs. All of them were mentioned. SGLT2, GLP-1. It's a good opportunity for people living with diabetes today. We have our partner, the WHO, giving our goals. 80% of people living with diabetes should be diagnosed. I think here in Qatar you are able to achieve this. But 80% of them should have good glycemic control. We hear the father of diabetes in Qatar that you do not achieve. Europe does not achieve. The US does not achieve. So this is a long way to go. And these are the WHO global diabetes targets for 2030. Yeah. Also blood pressure control in 80%. Statin usage in 60%. And 100% of people with type 1 diabetes should be diagnosed. So these are big challenges we have to address. And the challenges come from our healthcare system. We have very different infrastructure, different resources. Costs are often a barrier, not in Qatar and in the Gulf states, but in many countries worldwide. And to overcome this, we have to talk with providers. How is our guideline adherence? How is our therapeutic inertia? How are the communication skills to talk to the patient, to share ideas, to communicate also at scientific meetings? You are at the meeting. Not all colleagues are similar. If you really want to push this forward, we should invite all of them. We should discuss with them. We should not blame anyone, but invite everyone to walk together. But also on this patient side, there are obstacles as educational literacy, digital literacy, cultural aspects, especially in an environment like the Gulf states with high multicultural degree inhabitants. This can be a challenge on a day business. Finally, we have to understand our patients better. Very little. This slide shows you 380,000 patients here. How our lifestyle makes us getting diabetes by drinking. So you see 380,000 patients drink one soft drink per day for the period of 1 year. What it does with your diabetes. If you drink water, it's not increasing diabetes. If you drink orange juice and cola, 40%. But Diet Coke makes 60% diabetes per year. And the answer are the artificial sweetener. How can this be? Because it changes the microbiome. If you consume a certain threshold of artificial sweeteners, 38 are available, 36 do the microbiome change. They change bacteria. They eat the artificial sweetener. And this bacteria produce metabolites. What are the metabolites? They are a glucose molecule bond to fatty acids. A very strong bond. And this is basically the spool of this bacteria in our gut. We incorporate this, and it's getting stored in the liver. At the end, smart health will help us to change something also for prevention. You see here how young digital tools lower A1C. How can this be? We are in the pocket of our patient. We never have been so close to our patient than being in their pocket. And every one of us is taking 1,800 decisions a day. And 450 are related to our lifestyle. Now imagine the right smartphone application, in the right moment, with the right motivation, right educational strategy, we set impulses to influence only 10 out of the 450 lifestyle-related decisions. But do it over the period of 1 year. It's 10 kilogram or 12 kilogram or 12 kilogram of weight reduction. This is cool. And there are examples for modern diabetology like this. There are examples in Germany for licensed and reimbursed digital health application. Here one for diabetes education, another one where you make food and it doesn't matter what cultural environment you are. It's quantifying your food information is used to help to make a more healthy next meal, using the sensor for diabetes nutritional education based on the shape of the glucose curve, or a Swedish development, the diabetology out of the patient, using the sensor and comparing every reading with a swarm of all other patients using the same application. And this is making a very clear recommendation, like today at 6:35 you inject 22 units of long-acting diabetology out of the pocket. We might say, we don't want this because we are the diabetologists. Think about Rwanda, 360,000 people with diabetes and only one endocrinologist. And the digital infrastructure which is better than here in the environment. So this might be an opportunity by using AI to be disruptively positive in addressing the need of our patients. At the end, I want to touch the fasting again. We know that eating less is healthy, but maybe eating is even more healthy. If you fast for 2 weeks, it's the fastest gain of health you can generate due to the prolonged ketosis, which will start after about 4 days of not eating. That's why all the other fasting models, like intermittent fasting, like 5 to 2, 16 to 8, doesn't work in terms of liver fat, because you need 4 days to come into a prolonged ketosis. And then we will mobilize the liver fat and the pancreatic fat, we will change the microbiome. And you will gain a lot of health. This is an AGP of a person with type 2 diabetes after the fasting. And you see this flat glucose summarized over 14 days. And it's similar to the curve I showed you from the lady at the beginning. This is remission of diabetes in my eyes. This is MRI spectroscopy of fatty liver disease of a person with pre-diabetes. And this is before the fasting, and this is after the fasting. And I think this shows you what is the power of prolonged ketosis and total fasting for 2 weeks in terms of diabetes and chronic disease. I initiated a scientific committee to develop a guideline on fasting and diabetes. This guideline will be released in April 27 at the World Diabetes Congress in your hometown. And the guideline will address 19 different fasting styles. And this is a proposal for the water diet or the water fasting for 2 weeks, which is just under review. The review is done by this, or the group is led by this person. The group consists more than 120 experts, and they address different fasting styles for diabetes. This will be the first guideline on fasting and diabetes. We are just finishing a chapter for the new ASD guideline, which will be released next year. There will be already a chapter on fasting. I initiated on prevention of obesity and diabetes in adolescents, and they have released the public health program for diabetes prevention. There's a group on type 5 diabetes. I mentioned this already. This is related to a different kind of diabetes, a neglected kind of diabetes for more than 30 years, addressing about 48 million people with diabetes worldwide. This is a consensus group working on it, and they will come up also at the meeting in Qatar in 27 with a guideline on type 5 diabetes. So Qatar will be the hub of innovation, maybe disruption in diabetes care in the future. AI and diabetes, we will 2 days in Vienna at the global consensus meeting, team led by Dr. Amedei to translate AI as a tool into our diabetes care. There is a group also harmonizing the standards on type 4 diabetes, gestational diabetes. It's led by Dr. Mohan from India. And they will address the global consensus to harmonize the standards. And there's innovation in the IDF School of Diabetes, led by Dr. Amedei, to enhance the IDF School of Diabetes as the hub for diabetes education worldwide. Why IDF? Because we need a strong voice for people living with diabetes to enhance or build a community to improve the quality of diabetes care. And I truly believe that everyone has the same quality of care. But the challenge is accessibility and availability of diabetes prevention and care. In many countries worldwide. As president of IDF, I have three goals: to be in the brain of the politician, to be in the pocket of the patient, and in the heart of the healthcare professional. And how to reach this? Develop global diabetes index. So once a year, we will compare the quality of diabetes care, asking physicians and patients in every country in the world. Release the data for free before World Diabetes Day. For anyone to use. We want to build a momentum. The Minister of Health and we want to become better as our neighbor and to improve the care. Secondly, the pocket of the patient is using digitalization with a freely accessible diabetes education program for anyone to use. Think about the patient who has not enough money to go to the pharmacy or the physician, but may have a smartphone. And thirdly, the IDF fellowship program, you are invited to become fellow of IDF. Go to the website, apply for the fellowship program. There's a fellowship program, the senior fellowship program. And together we build a global community of actors to improve the quality of diabetes. IDF is 75 years. Indiana, we will celebrate this on Wednesday. It's not an old organization. It's an experienced organization. And IDF is all of us together, working together to improve quality of diabetes. Social media is important. If you want to scan this code, this is a direct social media channel to where we release the information and invite to participate. Don't forget this faces of people living with diabetes. Let's work together with all our intuition to finally be passionate and committed to improve the quality of diabetes care and help our patient to walk away from diabetes. Shukran. Thank you very much for your attention. And I apologize for not being in person with you.
Thank you very much, Peter. We are really witnessing a very fascinating and very exciting era for the IDF and for the diabetes care in the world. We will move now to the panel discussion, and may I invite all the respected faculty members to move to the center stage, and Professor Schwartz will be with us.
But I have to apologize. I will only be here for another 7 minutes, because then I'm chairing a diabetes meeting in India, and on my screen next to this one here, I see that there are already 2,800 people in the meeting, and in 7 minutes I have to switch to the other meeting. I apologize for this.
Thank you very much, all of you, for staying till the end with us. And now we will open the floor for discussion. So those who would like to ask questions, we will have at each corridor someone standing with a mic.
Thank you for the lectures. My question regarding pre-diabetes to Dr. Rishi. Frequently people ask about measuring their insulin level. Now, if we have a pre-diabetic patient, what is the difference between pre-diabetic with high insulin level or normal insulinemic patient? I'm speaking about in everyday practice. Is there any impact of high insulin, a patient with pre-diabetes with high insulin level or normal insulin level?
So the question is regarding patient with pre-diabetes and their fasting insulin. Some patients, they have high fasting insulin, and some patients, they have normal fasting insulin. Yeah, the high fasting insulin is just a reflection of insulin resistance. And probably insulin resistance is a step ahead of pre-diabetes. So you end up insulin resistant first, pre-diabetes, and then you end up with diabetes. But patient with high fasting insulin, just a step ahead of pre-diabetes as far as the numbers is concerned. But yes, I treat it as pre-diabetes stage if they have high fasting insulin.
Dr. Ahmed Bashir.
Can I comment? So in order to understand these data and the results, you have to, there are different algorithms that you can, or calculators that you can log in these data, a HOMA index, HOMA IR index, and HOMA beta index. You can calculate those online. So you enter the fasting glucose and the insulin over there. And they will give you numbers. So these numbers is going to tell you what is the predominant problem with this subject, with this person. Is it a predominantly insulin resistance? And it's going to tell you how much of the beta cells are functioning. So you can have a person who have a HOMA IR of say 5, or normally it's less than 2.5. So this is insulin resistance. But the HOMA beta can tell you that this pancreas is working by 200% or 300% or 200 plus or so on. So it can tell you where you are. So this person is overworking the beta cells, and this is probably going to exhaust the beta cells soon. So to make sense of it, I think using the calculator is good. And there are other methods to calculate the insulin resistance and the beta cell function.
Dr. Amin?
Just to you reminded me about my patients. They are asking about the insulin resistance. Always I'm telling them, go and qawmul Yahud, not qawmul insulin, because they are saying, please doctor, make for me the insulin resistance test. There is no insulin resistance test, but you can calculate it, as mentioned by Dr. Muhammad, that you will do the fasting blood sugar level, the total insulin level, times both of them over 22, which is a constant factor. You will calculate the so-called HOMA IR. If it is more than 2.5, this means that this patient is having insulin resistance. The higher the number, as mentioned by Dr. Muhammad, 5 or more, it is very clear. Some people, we get it as 10, 15, according to their obesity, total insulin, and fasting blood sugar in millimole. For example, 8 times 15 over 22. You calculate it and you can get it. If you have high insulin resistance, you have to think early, because you are approaching to get into the diabetes itself.
Thank you very much, Dr. Amin. Unfortunately, because we have Professor Schwartz has to leave for some pressing commitments, as we started late and we finished late. If I may ask His Excellency just to give us a sort of a take-home message, please. Peter.
It was fascinating to listen to the presentation, because they very clearly highlighted the different challenges in different stages of the dysglycemic continuum. And I would say this is actually the key message. It doesn't matter how you treat. It is important that you are confident in treating, but it matters to accept that there's a continuous pathophysiology of diabetes development. And from the logic, is it as earlier we act, as more aggressively we act, as more is it of benefit to our patient. Technology will help us in the future to diagnose better, diagnose earlier, to target therapies more to the physiology of the patient. And we will experience this in the upcoming 2-3 years already. But take home that it is important to act early. It is important to act maybe more aggressively than we can, metformin is a very cool drug throughout the whole dysglycemic continuum, but the blood vessels, the kidney, the brain, the heart, the lipid metabolism is thankful for a better glucose control as early as possible. It was a great honor to me to participate in the meeting with you. You are a fascinating audience. I will deeply thank to all the speakers for the presentation, for the discussion, for the pointing out the challenges and the innovation in diabetes care, and it was an honor for me to participate. Shukran. Thank you very much.
Thank you very much, Peter. Looking forward to see you in person in the near future. Thank you. Thank you for being with us.
Very soon.
Thank you. Bye-bye. Thank you.
Ciao.
Thank you. Right. So, any more questions, please?
All right.
Yes,
All right. Thank you so much, Dr. Williams from Qatar Red Crescent. Thank you to all our speakers for the very vital information we have gathered here. I'm just curious about a few points that were raised in some of the presentations. For instance, in the Indian diabetic prevention program, from the statistics, if I remember so well, there was no significant difference between lifestyle modification, use of metformin, and the combined, that's the combining the two, which looks a bit different from what we had in other countries or places. So I'm a bit curious, why is that? Is there a cultural issue? Is there a communication gap? Unlike what we expect and what's happened in other places, so why was there kind of results in that place? Anything, I'm just a bit curious about that as a scientist. So, the second question, now, the risk, before now, just like it's been debunked, there's a myth that you don't use metformin in pregnant women and gestational diabetes. But now, it's been approved that it can be used. Before now, I think the thought was that there are some fetal or maternal risk. Has there been, do we now have studies to show that there are no risk at all, or the risks are just minimal? Then, which is better? Is there any reason to pick either metformin or insulin? Because I think according to ACE, American College of Gynecology, they say either insulin, maybe insulin first or one of the two. So, question, any advantage of one over the other, or are they all the same in treating gestational diabetes for the use of metformin? Thank you.
Thank you very much. I think the first part of the question to Dr. Mohammed Al-Rishi regarding the Indian DBP, and the second part is destined for Dr. Mohammed Bashir. Al-Rishi first.
Yes, I think there's good observation, and that's why we mentioned about 4 different studies from China, from United States, Finland, and India. And you can see the outcome is only because the ethnic group probably between the Finnish study and the American study, the outcome, it was equivalent for the lifestyle modification. But if you look at the Chinese DDB prevention program or the Indian, you find there's a lot of the gap between the benefit of combining metformin and lifestyle modification. The Chinese showed a 65% reduction if you combine metformin plus lifestyle modification. But I agree, the Indian study, so probably cultural part, but the genetic part as well, because the South Asian characterized by more of central obesity. And you see the metformin is more beneficial in central obesity. How good the lifestyle program it was, I'm not aware of the details, but I'm aware of the American program and the Finnish program. So probably cultural plus genetic issue, but we see it in real life. Metformin works very well in South Asian population.
Thank you, Mohammed. The other Mohammed? Mohammed Bashir?
Yeah, so the question is...
regarding the metformin versus insulin in GDM.
Yes, so I'm trying to just summarize the question of how I understood it. So you're asking is, why is metformin not the first line endorsed by every society, or about any concern about long-term effects about metformin? So the metformin crosses the placenta freely. So there was initial concern about its risk with congenital malformation, and that was being shown, especially in cases where metformin was intentionally continued in women with polycystic ovary syndrome throughout pregnancy, that it doesn't happen. The concerns later on was about what's going to happen later on for those infants in terms of will it have any adverse effect on them. And metformin is being used in countries driven mostly during pregnancy from countries like South Africa, who's been using it from the 70s onwards for treating diabetes. It's providing more convenient for the patient because it's less, it's a tablet, not an injection. It's less costly if you look at the cost of insulin compared to the cost of a tablet of metformin. And then it's less costly in terms of the amount of strips that people use. In terms of safety, as said, multiple meta-analyses have came out to show that they're as good, if not better, than insulin in certain parameters. However, there are still concerns regarding metformin in two aspects. When there is a placental problem and there is a problem with a reduction in the nutrition to the baby, that metformin can worsen the situation at that point in time. And that's why generally people are avoiding it with these, when you have these scenarios. Or in our practice, if somebody is at risk of having these issues, we avoid them as well in terms of safety matters. But again, it's an ongoing topic, and maybe in the future we'll have more data.
Actually, the respected colleague over there, please. Go ahead, please.
Thank you for the scientific talks. I enjoyed very much with this talks. And my question is, I noticed from some slides the superiority of metformin 850 milligram BD, not superior for the change the lifestyle, even not superior for the interrupted fasting. So that is why we decide maybe patient need just change lifestyle and not give a long term for metformin with some side effects.
Actually, if you look, I got your point. The efficacy of the lifestyle modification is more potent of metformin. But if you look at the diabetes prevention program over 15 years, the patient early, the outcome is very good, 58%. But 15 years down the line is reduced down to about 20% plus. So the lifestyle is great. However, the challenge how to maintain the lifestyle for over a period of time. The metformin showed in the diabetes prevention program in 10 years and 15 years still continue to provide about 18% reduction or prevent progression to diabetes. So if you can do it with lifestyle, is always great. But the challenge with lifestyle, the continuation of the lifestyle. So that's why the role of metformin is there as well.
Thank you, Mohammed. Tayyib, if you could just make another comment, please.
I will go a little bit deep pathophysiologically. If you look at the exercising muscle, they are taking the glucose through the AMPK, not through the glucose transporter 4 receptors. So you have in the outside of the cell, you have the glucose transporter receptors that depend on the insulin to open those receptors. And you have the AMPK, which suck this amount of glucose. This is why you notice in the people who are exercising, even people who are taking other medication and insulin, you will need to reduce the amount of insulin that you are taking. And even more, we see that if the people inject the insulin near the exercising muscle, they are more liable to develop hypo. For example, if they are doing biceps or they are training the thighs, we usually advise them to inject in the other side. So I think it's the way that the exercising muscle are taking the glucose which help in reducing their progression of type 2 diabetes. And as Dr. Al-Rishi said, I think metformin will have another added benefits, but the exercise remains the same, and the data is clear. If you have a patient who even is 60 years old, this has reduced it by 71%. So I think this is the answer for why the exercise is having this benefit, which I agree it's less sustainable in the long run, but we can see data up to 10 years.
Thank you very much, Taib. Dr. Zafar?
Yeah, Dr. Bashir. You mentioned that hypertriglyceridemia is the mainstay in gestational diabetes. So is there any role of lipid-lowering agents in gestational diabetes?
Great. I was expecting this question. So what I've been describing here is a physiological changes that happen in pregnancy. So the change in the triglyceride levels is increased by 2 to 4 folds. That's from a physiological point of view. It gets worse in insulin resistance. So the triglycerides levels is a reflection of the whole process of obesity and visceral fat per se. Lipids as well will increase, LDL, HDL, and total cholesterol will increase. But these lipids, the increase in the LDL and HDL and total cholesterol is there to support the placenta and there to support the placental signaling and then the placental function. The triglyceride is a reflection of insulin resistance. The issue with it is that up to now we don't have a cutoff point of what's normal and abnormal high triglycerides. So we treat hypertriglyceridemia above a certain threshold, not to prevent all the metabolic issues I just mentioned, but to prevent future risk of pancreatitis during pregnancy. But when you look at the pathophysiology, it seems counterintuitive that why are we chasing glucose? Why don't we chase fenofibrates? Why don't we use fenofibrates and help with it? So because this is a physiological changes and this is reflecting the status of insulin resistance, there is a concern about fenofibrates use in pregnancy because of the high risk of congenital malformation. People are looking at omega-3 and looking at other one, a medication called
ezetimibe?
No. It's a supplement, mannitol. They're looking at this from this aspect because it seems to tackle this part of the pathophysiology and improves the overall glycemic status. But as we speak right now, they're not used for this purpose.
Just an added comment from Dr. Rishi and then the respected doctor, please.
Just to mention about the lipid lowering, all the lipid lowering medication during pregnancy is contraindicated for the time being. I came across a patient actually in the UK who admitted with acute pancreatitis during pregnancy. She was 33 weeks pregnant and her triglycerides was 38. With a discussion with my colleagues in central London, we give her omega-3. There's one type of omega-3 does not cross the placenta. So it was given for about 4 or 6 weeks until she delivered her baby. Then we optimized her medication after pregnancy. But this is the only omega-3 does not cross the placenta. The name is not on top of my head.
But it's just so fenofibrates can be used after the first trimester, especially mid-second trimester, to reduce the risk of pancreatitis if the fasting triglycerides above 5. So it could be used, but only to reduce the risk of acute pancreatitis, but not early on in pregnancy. And now because of the presence of omega-3, so omega-3 is now the first line. And if you can't get it down, you use fenofibrates. And the target is to keep it under 5 millimoles per liter.
One quick last question.
Yes, I am Dr. Ahmed Mahmoud. I am a family physician. I would like to raise the issue of, in spite of polypharmacy of treating diabetes, still the control of diabetes is not improved in terms of hemoglobin A1C. So I would like to raise the issue of adherence of patient to medical treatment. This very, very important issue. In spite of all these medications and all this, still the hemoglobin A1C is still, we didn't achieve the targets of achieving control of diabetes.
Thank you very much. I think it is a very important. We can't agree more. And just quick, if there is any added comments before we conclude from my other respected faculty panel.
I think he nipped it on the head. So adherence is the main problem. So we were talking about diabetes prevention program now on metformin, and the same diabetes prevention program showed that people who take the metformin, they lose 5% of their body weight and sustain it. People who don't take it don't benefit from it. And adherence is a problem, but and recent data from GLP-1 receptor agonists that have been published recently showed that if it is being given for obesity, only 30% use it after over 12 months and they stop. If it's being given for diabetes, under 50% are using it within 1 year, despite its huge amount of benefits in terms of diabetes reduction and weight reduction. So you're absolutely correct, but this will be another issue. Are they adherent because they're not taking it? Are they adherent because they're not adherent because they cannot buy it? What is the main issue? So yes, there is a problem with adherence, but the question is why they're not adherent.
Thank you very much, all my respected faculty members. Just to announce that the sort of late lunch, early dinner, late dinner will be actually in Teatro Restaurant, level 2. And don't forget, please, to scan your QR code in order to get your points and have the evaluation and the feedback. Again, thank you very much for all of you. Thank you for the choice. Thank you for Merck for such a very wonderful, and would like to thank all my respected faculty members. Thank you very much. And if we can just move for a sort of a group photo before it disappears, that will be highly appreciated.